Can you hear me?
Yeah, I can. Yeah.
Hi.
Hi.
So we are going to sort of interchange between Karnik Madam and...
Yeah.
Right. So the thing is, Karnik Madam will speak first and then there'll be the oration and then the panel discussion, right?
Yeah, the panel discussion will be last. By the time Karnik Madam finishes, hopefully Madam will join. Yeah. Okay.
Dr. Madam, you can start.
Yes. A very good morning to you all, my teachers, my seniors in the audience, and my friends. I welcome you all for this CME on neuroanesthesia. Neuroanesthesia is a specialty in itself, but we, as anesthesiologists, in any part of anesthesia, in general anesthesia, or any other specialty like trauma, if we are a part of it, we find that neuroanesthesia is something which we have to know, because a head injury patient can come for any other surgery. A patient which has any spine injury can come with any other surgery. So we have to know the practical aspects of neuroanesthesia in a day-to-day practice and the challenges which we may have to deal therein. So today we have some eminent speakers, Dr. Hemangi Karnik, Dr. Bharati Kondwilkar, who will be throwing light on this, and Dr. Malati Panchawagh, who will be a part of our panel discussion on the traumatic brain injury. Today is Teachers' Day, and I begin with a salute to all my teachers, students, and seniors as well as colleagues in this audience. Even my students have been the guiding force to what I am today. And through this journey of anesthesiology, actually it has been all my teachers and my students who helped me to go through this journey of anesthesiology. We would like to dedicate this webinar to Dr. A.M.Deshpande sir. Now, due to some technical difficulty, we have not been able to start with Dr. Kondwilkar's lecture. So we will begin with Dr. Karnik's lecture first and then move on to Dr. Kondwilkar's lecture. I welcome Dr. Karnik.
Good morning, everyone. I would like to introduce our speaker, Dr. Hemangi Karnik. The madam is a professor in anesthesiology at Lokmanya Tilak Medical College and Hospital in Mumbai. Madam's special area of interest in anesthesiology are neuroanesthesia, neurotrauma, and monitoring. She is an editor of a book named A Practical Approach to Anesthesia for Emergency Surgery. Madam is a reviewer for 5 journals and she is a member of the editorial committee of Journal of Neuroanesthesiology and Critical Care. She has more than 40 publications and 9 chapters in various anesthesia books. So I request Madam to begin with her topic. And for delegates, if you have any questions, please put it in the Anesthesia TV chat box. It will be answered at the end of session. Madam, please.
Thank you for the nice introduction. And very good morning to all. At the outset, I thank Society of Anesthesiologists Pune for giving me this opportunity and honor. And especially my special thanks to Dr. Pradnya Balirao Madam. Now coming to the subject. Are my slides visible now?
Yes, madam.
So coming to the subject itself, eras in neurosurgery. Now, as enhanced recovery after surgery is not a new subject for most of us, and many of us are even practicing it today in our regular practice. However, when it comes to neurosurgery, the practice is still less. Very few people are actually practicing eras in neurosurgery. Maybe because of inadequate evidence, or probably still the guidelines are not there, and that is why. And so that is exactly what I would like to elaborate upon in today's lecture rather. Enhanced recovery after surgery is a systematic multimodal perioperative care provided to reduce the surgical stress of the patient and thereby facilitating early recovery. A point to be noted over here is many people confuse ERAS with the daycare surgery. ERAS is not equal to their daycare surgery. However, the principles of ERAS can be used in some of the select group of patients, which can help in enhancing the recovery so that they can be discharged on the same day after the ambulatory surgery or daycare surgery. So this is how ERAS can help in daycare surgery, but it is not equivalent. ERAS was first introduced by Dr. Henry Kelly in early 1990s. It was also called as fast track, accelerated or rapid recovery protocols. Initially, it was used for colorectal patients with the goal of improving their functional capacity after the surgery and decreasing morbidity. Later on, the ERAS term came into play. It involves multiple recovery pathways which are combining in a multiple optimized clinical procedures which are to be provided in the pre-hospital, preoperative, intraoperative, post-operative, and even post-discharge phase by surgical team, anesthesia team, nursing team, all together, and multiple components are to be given, and all together it may help in enhancing the quality of recovery and maybe early discharge. Now, as you can see, the anesthetists take an important part or important role in almost all phases of this ERAS. Even before admission, we can help in medical optimization of the patient, including control of the comorbidities, immediate preoperative phase by properly giving the nutrition in the preoperative phase, minimizing the starvation phase, PUNE prophylaxis. Intraoperatively, we have many things in our control, like type of anesthesia that we choose, the drug choices, dose, fluid balance, temperature control, and so on. And even post-operatively, we provide adequate pain relief and other monitoring and prevention or identification of complications and so on, about which you will be listening little later. So what is the purpose of ERAS? Let me explain that with this particular graph. The blue is the baseline functional status of the patient at which he has first sought the medical attention, and this is the time when the first surgeon probably or an anesthesiologist has seen the patient. Now look at the black graph. As the patient is awaiting surgeries, his condition either may remain same or may come down because of the disease process itself or for some because of some other factors. And when the surgery occurs, there is a sudden major drop in the patient's functional capacity, and quite often it may go down below the critical level. With the traditional approach, slowly the patient recovers, initially in the hospital and later on convalescence phase in the post-discharge phase. Now, in this patient, if ERAS protocols are applied, what we expect, as shown in the red graph, the ERAS is likely to cause the less dip in their functional status so that early recovery can occur and the same functional status can be achieved earlier than with the traditional help. Now add upon that the prehabilitation. So if prehabilitation is incorporated, the patient's basic functional status itself improves. For example, correction of anemia. So when the patient undergoes surgery, we can minimize the drop in the health, maybe avoid the critical level altogether and have early recovery, enhance the recovery back to the health occurs much earlier so that the patient's hospital stay is shortened. There are chances of lesser readmissions, lesser complications, better patient satisfaction, and so on. So who wouldn't like to do ERAS or apply ERAS in their practice? So slowly, as the ERAS popularity increased, the ERAS Society was formed. It was formed officially in 2010. However, the idea was, or the concept was originated in 2001, and it was known as the ERAS Study Group earlier. And slowly, as it expanded, they have developed certain guidelines. And till now, they have given 33 ERAS guidelines for different procedures, mainly cancer procedures and so on, different types of surgeries, including cesarean sections, cardiac surgery, and even for lumbar spine fusion patients, the guidelines have been given. Unfortunately, we are still awaiting guidelines for craniotomy or neurosurgical patients. When it comes to neurosurgery, the ERAS is still slow to take place. Maybe because there is not enough evidence available. Maybe because our patient population is not same. What we encounter is absolutely awake, conscious, fit patient coming for surgery. On the other extreme, there are absolutely long time bedridden patients, moribund patient, unconscious patients, dependent on life support system and all. And applying any specific protocol to all the type of patients is just not appropriate. So that is why probably it is slow. But unfortunately, neurosurgical patients are the patients who are likely to be most benefited by ERAS type of protocols, because there are inherent morbidity and mortality attributed to the disease per se. There is a higher risk of postoperative cognitive dysfunction and reduction in functional status postoperatively. There is a higher risk of postoperative events like stroke, myocardial infarction, death, infection, and resurgeries. And unfortunately, the outcome degrades exponentially if the perioperative care is not proper. What type of perioperative care the patient receives affects the outcome very, very significantly in neurosurgical patients. And how the ERAS can help? ERAS may decrease the period between surgery and the resumption of daily activities. It can also help in rapid discharge, which can allow the patient to go for early for the residual, the remaining treatment like chemotherapy or radiotherapy and all. So overall outcome may get benefited. And in our country, especially where all the patients are not under the gambit of insurance, it definitely reduces the financial burden on family. However, a delicate, well-balanced protocol is needed which suits our own setup. Do we have any evidence that ERAS helps? We do have it, but however, it is not a very tremendous large amount of studies or something like that. The first systematic review article came in 2016, an excellent review article done by Catherine Hagen et al. They reviewed the evidence available, reviewed the 551 articles, and all those articles were reviewed as per the grade systems, and they have given 17 recommendations to employ ERAS in neurosurgery, and this is what I will elaborate in detail about. They have given various domains have been reviewed: preoperative, intraoperative, and postoperative for oncological craniotomies. Based upon the evidence available, they have given the recommendations, and some recommendation as shown over here, like preoperative counseling. Even if the evidence level is low or moderate, the recommendation given is strong, because either even though the level of evidence is low, they are extremely useful, or they are having least negative effect or harm to the patient. So the recommendation might be strong. So let us see each of these recommendations one by one. Coming to preoperative elements, the preoperative components are aimed to optimize the patient to the best of its capacity. The goal is to achieve an informed, prepared, physiologically optimized patient who knows about the surgery and anesthesia. And the patient education is the first component of that. It helps in preparing the patient and his caregiver psychologically and to have realistic expectations of post-operative recovery. The key word is realistic in neurosurgery. It's really important. It helps in clearing their doubts and reduce stress. Significant impact of patient satisfaction is likely to have because of that. So the recommendations are: patients should be routinely counseled regarding what to expect from their surgical experience. And what should be told about? The risk associated with the procedure, approximate length of stay, perioperative carbohydrate loading, fasting, pain control, early ambulation, postoperative feeding, timing of removal of catheter, as well as the long-term functional status that is expected should be explained. Next is patient counseling about the preoperative smoking and alcohol consumption. We all know that the smoking and alcohol consumption can possibly increase the risk of postoperative morbidity, and pulmonary complications significantly can reduce if the smoking is not observed or abstinence is observed for a month before surgery. So it is strongly recommended to follow abstinence from both alcohol and tobacco for 1 month when it is appropriate and feasible. Coming to preoperative enteral nutrition and perioperative oral immunonutrition, preoperative nutritional status is associated with increased morbidity and length of stay in the surgical population. Nutritional deficiency is a strong predictor of 90 days mortality, and immunonutrition is associated with enhancing immune response, and it also allows the adaptation of systemic inflammation and oxidative stress. So the patient gets adapted to this stress better, and therefore enteral nutrition is recommended preoperatively, and immunonutrition may be important in patient with cancer. So far the evidence is available that it helps in patient with cancer only. What should be done? Supplemental hematinics should be provided, anemia should be corrected. Whatever are the shortfalls preoperatively, try to correct it in whichever available time. Correction of nutritional deficiencies should be done. Extra micronutrient supplementation along with the regular diet should be provided, and in patients with hyperglycemia, corrected preoperatively. Preoperative fasting and carbohydrate loading is another preoperative element that is there. We have, especially in neurosurgical population, we had a major hesitation about the carbohydrate loading. So what does the evidence say? The rationale is preoperative stress leads to catabolic state. So if you load the patient with perioperative carbohydrates up to 2 hours prior to surgery, it has been shown to attenuate insulin resistance. It improves the muscle function by reducing nitrogen and protein loss. It improves the subjective feeling of hunger, thirst, and postoperative fatigue. No effect on postoperative nausea and vomiting occurs if you are loading the patient with carbohydrates. What should be done? Avoid repeated prolonged fasting. Clear liquids can be given up to 2 hours before surgery. Avoid hypoglycemia. And in another study done in non-neurosurgical patient, another review article, they have recommended that solid food can be given up to 6 hours preoperatively, and up to 400 ml of carbohydrate load can be given 2 hours prior to surgery. The neurosurgical recommendations are, as carbohydrate beverages are clear liquids, preoperative carbohydrate loading should be encouraged even in craniotomies. A small word about carbohydrate loading. This is coming from non-neurosurgical cases. A systematic review, Cochrane review, was done by Smith et al. About carbohydrate loading, and it has been found that it reduces the length of stay without effect on postoperative complications. Any commercially available carbohydrate alternative can be used, even though there are specific pre-surgery fluids are available. One can use the clear fruit juices, clear tea, black coffee, carbonated beverages, and so on, as long as the formulation is clear and residue-free. Carbohydrate loading can be safely used even in non-insulin dependent diabetics. Even in insulin-dependent diabetics, it is not associated with hyperglycemia. However, it is prudent to monitor blood glucose levels at regular intervals in such high-risk patients. The next element is antithrombotic prophylaxis. Neurosurgical patients are at high risk for developing venous and arterial thrombosis because they are prolonged bedridden, dehydration is common. The use of graduated compression stockings and intermittent pneumatic compression is recommended in craniotomy patients to prevent venous thromboembolism. And there is an evidence that the routine use of anticoagulants like low molecular weight heparin is not recommended due to increased risk of intracranial hemorrhage. What has been found to be useful is active or passive physiotherapy in these patients. In fact, it has been observed that the relatives are very happy to help for passive physiotherapies because it gives them something to do. Coming to antimicrobial prophylaxis and skin preparation, it has been proven that there is no difference in surgical site infection among patients whether the patient's scalp is shaved versus unshaved. Unshaved meaning either limited scalp shaving is done or clipping along the incision site is done. So the recommendations are minimize scalp shaving. It enhances the patient's outlook towards the surgery, patient's confidence, and it helps in outcome. Staphylococcus aureus is the most common organism responsible for surgical site infection after craniotomy. So it is recommended that a single dose of broad spectrum antibiotic like cefazolin should be used at least 1 hour prior to surgical incision. And if the surgery is major, long lasting, or involving large blood loss, even at least 1 additional dose should be provided. Even though there is no proof in craniotomy patients, something about midazolam. Quite often we give 1 to 2 milligram commonly used for anxiolysis. However, it may delay the emergence from anesthesia. It is associated with increase in post-operative cognitive dysfunction. There is an evidence that it causes pharyngeal dysfunction and discoordinated breathing, and swallowing may get affected. It also affects the quality of recovery. And so therefore, routine use of midazolam is discouraged, particularly in patients who are elderly, morbidly obese, sleep apnea, and those having impaired gag reflex patients, like our posterior fossa surgery patients and all. Coming to intraoperative elements, scalp infiltrations and scalp nerve blocks both have been known to help in providing intraoperative as well as postoperative pain relief. There is a reduction in doses of general anesthetics agents as well as opioids. There is a reduction in stress response and reduction in the incidence of postoperative IVS. How much reduction postoperative pain can take place will depend upon when the block was given, how long was the surgery, and which drug was used. If it is given at the end of surgery or if the surgery is shorter lasting, obviously we will get more effect postoperatively. The recommendations are both scalp infiltration and scalp nerve blocks are recommended for craniotomies, whichever is appropriate for the case. Anesthesia protocol, our goal for neurosurgery is rapid emergence anyway for all cases, because we want to do early neurological assessment. So we usually use the anesthesia technique having minimal postoperative hangover and minimal effects on gastric motility. We use it using different types of drugs or drug combinations for the techniques. The current evidence does not support the superiority of short versus long-acting anesthetics or TIVA versus inhalational agents. So probably this may be because the exact drug choice is not important. Which drug you use is not important, but how you use it is more important. Like when you are switching off the particular agent, what concentration you are using, and all those different things do matter in outcome rather than which particular drug you have chosen. Of course, there are multiple RCTs available. Mostly they are involving sevoflurane, remifentanil or fentanyl, but no significant differences have been found in these RCTs between TIVA and inhalational anesthetics, between long versus short-acting opioids. Propofol remifentanil has been shown to attenuate increase in glucose concentration. However, when compared with isoflurane, however, no difference has been found in the cortisol levels or insulin responses. Nitrous oxide has been shown to increase the cerebral metabolic rate of oxygen, increase cerebral blood flow, thereby increasing ICP, also increasing the PONV incidence. So therefore, it is not a very good choice to be used for ERAS in neurosurgery. There is some evidence available for 3 adjuncts to general anesthesia. Ketamine has a potential to reduce hallucination, nausea, vomiting, and sedation, and therefore it is undesirable in neuroanesthesia practice. Dexmedetomidine has an analgesic effect, so it is helpful and maybe can be recommended as a component of anesthesia technique. Lignocaine, even though it is useful For abdominal surgeries in neurosurgical cases, it has unfavorable sedation profile and therefore is not suitable drug as an infusion. Coming to analgesia, we want to facilitate optimum pain control, but at the same time accelerate the patient recovery. So therefore, multimodal analgesia is most commonly used using multiple techniques. So select analgesics which have minimum effect on cognition and orientation after the surgery. The tendency is to exclude longer acting opioids due to their undesirable side effects. If you use a longer acting opioid, there can be post-operative sedation, nausea, vomiting, which can hinder the prompt recognition of post-operative intracranial catastrophes. Even the post-operative respiratory depression effect can also increase the CO2 and ICP can rise and it can affect the intracranial hemodynamics and are not good. So even though RCTs do not prove it, usual tendency is to reduce or not use such kind of drugs. So when you are not using or minimizing the opioid usages, what else can be used? There are several options for non-opioid analgesia because craniotomies are associated with moderate to severe pain and we must have adequate analgesia. Gabapentin is effective in decreasing postoperative pain and analgesic consumption. But if it is given for prolonged, multiple days, prolonged administration is associated and higher dosage are associated with delayed recovery and delayed extubation times. So that should be discouraged. Similarly, pregabalin, prolonged administration, there is some proof that it may cause mild negative cognitive effect. But the evidence is very sketchy only in volunteers and really we cannot say that it is bad. Tramadol is less effective as compared to morphine and there is an increased risk of nausea and vomiting, so it is not a very good choice. NSAIDs, we have the bleeding concerns. COX-2 inhibitors, we have the conflicting results as far as the proof is concerned. But two drugs which are showing some promise, flupirtine, a centrally acting aminopyridine, non-NSAID, non-steroidal analgesic has been found to reduce the risk and therefore is likely to be coming up in a better way for craniotomy cases. And IV paracetamol, which most of us are using, is an effective analgesic, reduces PONV if given before the starting of the pain and should be a part of our multimodal pathway. Coming to fluid balance, our goal is to maintain a state of euvolemia, minimize salt and water excess, and provide an optimized operating field. We do not want overhydration, which will cause cerebral edema and so on. But our craniotomy patients quite often come on table with relative fluid deficit, which is common due to dehydration, restrictive fluid therapy, use of diuretics, and so on. So when we minimize the preoperative starvation period, it helps. Those who are unable to take orally, probably parenteral fluid might be a good choice. And intraoperatively, we need to balance between the dehydration and overhydration. Usually isotonic crystalloids are used. But because we want a tight balance, closer monitoring on the hemodynamic parameters, specific hemodynamic monitoring is warranted to achieve nice balance, and it is recommended that the non-invasive cardiac output monitoring like NICOM or any other type of hemodynamic monitoring would be able to provide us accurate determination of volume status and should be used when appropriate. Maintenance of normothermia has been shown to decrease the cardiac events, especially arrhythmias, bleeding and blood product transfusion requirements, wound infection, pressure ulcers. On the other hand, hypothermia has been shown to prolong the neuromuscular blockade and it can prolong the anesthetic recovery, and therefore it is recommended, strongly recommended, that measures to prevent hypothermia should be implemented for all craniotomies, and it is very easy, can be done very easily. Minimally invasive craniotomies and endoscopic endonasal skull-based surgeries are likely to have improved self-perception and early return to work because of the cosmetically hidden incisions, less tissue dissection leading to reduced postoperative pain. Patients are feeling self-confident. more confident, and therefore it is helping even in starting of the adjuvant chemotherapy. But really, do we have the option of doing conventional craniotomy versus minimal or changing the type of surgery? Very few patients have these choices. And therefore, obviously, we have lack of RCTs and the very weak evidence is available. Therefore, the recommendation for going in for minimal surgery in craniotomies or neurosurgical practice is extremely weak. Coming to post-operative elements, post-operative nausea and vomiting. There is a very high incidence in post-craniotomy patients, and it can also be longer lasting for beyond 2 days. It can lead to increase in ICP, increased risk of intracranial bleeding, brain edema, and maybe lead to pulmonary aspiration. Our regular drugs are routinely, that we use routinely, are also effective in neurosurgical practice, like serotonin receptor antagonist and dexamethasone. Even the transcutaneous electrical stimulation at P6 point also has been shown to have some favorable benefit. Scopolamine and promethazine have side effects like sedation and therefore are undesirable in neurosurgical practice. The recommendation is for minimum use of drains and invasive catheters in neurosurgical practice. The early bladder catheter removal should be promoted in order to avoid increased infection rate and promote mobility of the patient. Insert the nasogastric tube only if needed and remove at the earliest if appropriate. Similarly, insert the surgical drain only if needed and remove as soon as it is not required. Post-operative nutrition is extremely important, however, quite often neglected part of this. There is a high level of catabolism and hypermetabolism in these patients. In fact, the trauma patients have been known to have about 140% requirement of energy in their ICU stay. Huttle et al. Has done one study and they have found that in traumatic brain injury, every 10 kilocalorie per kg decrease in caloric intake is associated with a significant increase in mortality rates. And those who are having who are in semi-comatose patient for longer than 7 days, if you give the good nutrition, their outcome is improved if the TPN is given. So therefore, the recommendations is nutrition should be provided and it should be provided early for beneficial of neurosurgical population, and it can lead to early recovery. Early mobilization prevents the loss of muscle mass, helps to prevent deep venous thrombosis. However, to achieve this, one must give the adequate pain control, preferably using the non-opioid analgesic, and also prevent PUNE. And the recommendations are patients who are free of motor deficits, they should be mobilized as soon as possible, preferably on day 1 post-op day. So recommendations, encourage early mobilization, but not so early as shown in the picture. We should have some discretion in who can be mobilized. Another aspect of ERAS protocols is auditing our own protocols. Check for the compliance, whether the protocols are followed or no, which component is not being followed, what can be done to improvise that, which complications are still occurring, and how we can avoid that. Follow up the patient later on also, and then come back to our protocols, modify the protocol where the system is lacking. And all those things are absolutely essential to ensure the success or failure of your protocols. The compliance data also will help in comparing our data with other centers who are also utilizing similar measures. And feedback can help us in improving our own protocols itself. So after this article, review article from the Catherine Hagen, there are several more articles coming for ERAS for neurosurgery. And one of this has come from the AIMS review article by Rajiv Mishra et al. And they have also reviewed the articles, and what they have said that the adherence to ERAS for craniotomies may improve patient outcome, accelerate functional recovery, and decrease length of stay. but this is just a review. They have not done any study. Few studies are available. Wang et al. In a military hospital in China conducted a safety and efficacy of ERAS in elective craniotomy. In 140 number of patients, this was, mind well, this was a randomized controlled trial, and the results said strongly in favor of ERAS protocol. What happened? The total hospital stay was significantly reduced, and especially the post-operative stay was significantly reduced. They concluded that the implementation of ERAS is associated with a significant reduction in the post-operative hospital stay and an acceleration in recovery without increasing complication rates related with the elective craniotomy. As you can see, there was no increase in readmission rate or any reoperation rate as well. However, a point to be noted that this was a military hospital in China, so the compliance rate is likely to be much higher than most of our centers may encounter. They looked at the hospital length of stay, but is it the only important thing? It was of an outcome of interest in the beginning, but it is only a surrogate marker of recovery. We need to look at the other markers of early recovery. The hospital discharge in our practice actually depends upon many other factors than the patient's well-being only. It also depends upon whether patient is coming from the same city or another state, or the financial condition, and many more things. And not to consider that the recovery is not complete at the time of discharge. It continues for a long time even after the discharge. So therefore, we need to look at the other aspects also as far as the recovery is concerned. So the same group of people, Bolin, Liu, and Wang, and others in the same hospital did other studies. Neurosurgical ERAs were employed to assess the patient satisfaction. And what they found, that the mean patient satisfaction was significantly higher in ERAS group. The important predictors being age, PUNE, VAS score, use of absorbable skin sutures, and postoperative length of stay. And therefore, ERAS helped over there. In another study, they checked the impact of ERAS in health-related quality of life, and they found that the neurosurgical ERAS program seems to improve the functioning and symptom scores in glioma patients. Johnson et al. Did a quality improvement project using the ERAS pathways using quality of recovery 15 scale. Again, they did two groups. First, without implementation of the ERAS, and then the second group was with implementation of the ERAS. And they checked the QR15 baseline as well as postoperatively till 24 hours post-op. And they found that at 6 and 12 hours time points, the pre-implementation group had very worst quality of recovery. And when they employed a proper analgesia protocol, they used preoperative dose of 4 milligram eprepitant and a pre-incision dose of paracetamol, followed by immediately second dose on arrival to recovery. And then they could achieve a better quality of recovery at this 2 points, 6 and 12 hours. So a proper analgesia protocol must be followed according to them for improving the quality of recovery. Back home, again in the, coming back to India, AIIMS Bhubaneswar did again a non-randomized controlled trial employing ERAS in neurosurgery in 70 patients. They also used the similar protocols that most of the other people used, but they used preoperative flupirtine oral tablets for analgesia and also continued the same tablet post-operatively. And what they found, that less number of patients in ERAS group required longer ICU stay. And VAS scores in ERAS group was much better as compared to the control group. ERAS protocols have also been used for specific neurosurgeries like MVD surgery, major spine surgery, pediatric craniofacial surgeries, and all. And everybody has said that the ERAS has helped them in early recovery. What about our own experience? We have also done one study in our hospital between 2017 to 19 to evaluate effectiveness and of modified ERAs on quality of recovery using QOR 50. We wanted to assess the post-operative patient satisfaction. And again, our study was also non-randomized. We did 49 cases, checked the quality of recovery for 9 months using the traditional approach. Then followed by that, there was a 3-month training period, intensive training period for the all staff of the neurosurgical ward, ICU and OT. And after that, we employed ERAS protocols and rechecked the quality of recovery up to post-operative day 2. We use the 5-point Likert scale for patient satisfaction and QOR 15. We use the ERAS protocols using the recommendations by the Hagen et al. In fact, they had just come in, just published at that time. We use the ceftriaxone 1 hour before the incision. Midazolam was not given. Instead of high dose of fentanyl, we use the 1 microgram per kg and then split it up into multiple small dosages. Paracetamol was used as a part of our multimodal regime. Scalp nerve block or anesthesia, local anesthesia infiltration was used for all patients. We used PPV to guide fluid therapy, and we started using balanced salt solution. Our results, both the groups were comparable. ERAS groups received significantly lesser amount of fluid. Better post-operative patient satisfaction was seen as shown over here. The ERAS patients were able to enjoy food better, able to sleep better. They were able to look after their own better. They were feeling that they are getting adequate support from the hospital staff, feeling comfortable, overall had better experience about the pain, and overall quality of recovery was better in ERAS patients. So thereafter, we are still continuing most of our components of ERAS. A few points that we noted is avoid upfront loading of opioids before pain stimuli. If you give too much of opioids first, then the requirement also increases and the more analgesics will be required. Always use age-adjusted MAC values. And it is preferable to use BIS monitoring to monitor the depth of anesthesia and NMT monitoring to achieve the depth of paralysis. Instead of giving too much fluid in response to hypotension, it is better to use small doses of either phenylephrine or ephedrine if the patient doesn't respond to first bolus dose of fluid, and keep the patient hemodynamically stable. Consider lung protective ventilation to use the patient using patient's ideal body weight rather than the actual body weight, and avoid frequent rescheduling or delays. And that is one troublesome point that we have encountered in our practice. So after all this experience and searching the results, all the articles, literatures and all, what is the bottom line? Do we have enough evidence to use ERAS in all craniotomy patients? Indu Kapoor et al. From AIIMS New Delhi did one systematic review looking at outcomes like duration of hospital stay, post-operative pain, hospital cost, surgical and non-surgical complications, patient satisfaction and hospital mortality. And still, we do not have enough evidence that ERAS helps. What they found based upon the articles is compared with the conventional management, and ERAS approach was not associated with the shorter length of hospital stay, improved pain score, reduced complication rate in patients undergoing craniotomy. So maybe because there are still paucity of literature or RCTs, we still do not have clear evidence. However, individual experiences are there in the positive way. So to summarize, ERAS is a multidisciplinary approach. ERAS in neurosurgery is still a developing concept. Few reliable studies are available which can guide us, and the goals need to be defined, whether we want to employ this for early discharge, whether we want cost cutting, or we want patient satisfaction before we employ the protocols. The protocols need to be modified as per the facilities available in once set up per se, and cooperation from all team members are needed. We need to first learn the ERA's principles, protocols, unlearn what we were doing earlier, the traditional approach, apply ERA's, and then relearn from our own experience the newer data available and remodify our protocols so that we can help the patient in improving the outcomes. Quite often, all the components of ERAS may not be possible to employ. For example, we may not have time for preoperative optimization in neurosurgical cases. But in that case also, whatever components we can employ may help in improving the outcome, and that is what we should strive to achieve. Thank you.
Thank you, madam, for such a wonderful, informative, and evidence-based presentation. So here we, the Society of Anesthesiologists of Pune, would like to felicitate the Dr. Hemangi Karnik madam for the same.
I'm unable to stop sharing.
Ma'am, there is an icon on the top which says stop share.
Okay, I got it.
You got it?
Yeah.
Thank you very much,
Thank
ma'am.
you.
Yeah. Now, for those who may have logged in late, as we all know, today is Teachers' Day, and today is the day where we would like to acknowledge what our seniors and our teachers has given to us. Now, here I would like to specially introduce the late Dr. A.M.Deshpande, sir. Dr. A.M.Deshpande, or AMD as we would call him, was a larger-than-life figure. He was a numero uno among anesthesiologists. Popularly known as Balasaheb Deshpande, he was born on the 3rd of September 1932 at Karad. He graduated from the BJ Medical College, Pune, and was a resident in the Sassoon Hospital from 1959 to 1960. Thereafter, he did his diploma in anesthesia from the Bombay University in 1961 and worked in the UK for 2 years to achieve his DA London. Thereafter, he joined as an honorary associate professor at the BJ Medical College, and he was an honorary associate professor between 1965 to 1970. After achieving a postgraduate degree in anesthesia in the then Pune University in the 1970, he joined as an honorary professor in the Department of Anesthesiology between 1970 to 1992, and thereafter he was the Professor Emeritus from 1996 to 2012. Dr. A.M. Deshpande, sir, was a different person in himself. He was the pioneer who actually thought we should have conferences in Pune, and hence the 26th annual ISA conference was held in Pune in 1976 under his chairmanship. He was the founder member of the Pune City branch of Indian Society of Anesthesiologists, a founder president of the Maharashtra State chapter of Indian Society of Anesthesiologists, and also the chairman of this board of studies of the Pune University, under which the BJ Government Medical College was there. A prominent figure at state, national, and international anesthesia conferences, we, a few of us in BJ, had the chance to be a part of his team and present symposia at various state level conferences. a pioneer who established the concept of cardiac anesthesia, not only in the BJ Government Medical College, but also in Pune overall. And he started the concept of the requirement of a group practice in cardiac anesthesia. And he has several distinctions to his credit. He has always been a very compassionate person, helpful, and strived for the best. And in fact, he derived the best from all of us too. Society of Anesthesiologists Pune dedicates this CME on neuroanesthesia to Dr. A.M.Deshpande sir. Now moving on to Dr. Sushma Tandare.
I would like to introduce our esteemed speaker for the Dr. A.M.Deshpande Oration, Dr. Bharati Kondwilkar. Madam is a former professor and head of Department of Anesthesia at Sir J.J. Group of Hospital, Mumbai. The madam's special area of interest is neuroanesthesia. She has been felicitated as a distinguished teacher in neuroanesthesia by Indian Society of Neuroanesthesiology and Critical Care. She also has been felicitated with late Dr. Suresh Wagh Endowment Oration and late Dr. Harivir Singh Memorial Oration. She has a numerous publications and presentation at national and international level in her name. So I invite Madam to begin with her topic, the complications encountered in neurosurgical anesthesia. Can we avoid them?
Madam, you can share your slide now.
Hello? Hello?
Hello, ma'am. We can hear you. Yes.
Can you hear me?
Yes, ma'am. Yes.
Okay. Good morning to everybody. Sorry, I was a bit late, so I think I was put after Hemangi, but it was privileged to hear Hemangi, meeting her after a long time, at least on the Zoom meeting. We always flock together in neuroanesthesia group. On this occasion of Teachers' Day, I pay my respect to all the teachers in audiences and otherwise. It is really very nice to have this CME on a Teachers' Day, to pay the respect and to late Dr. Hello, can you hear me? Hello? Hello?
Ma'am, we can hear you.
To pay my respect to Dr. Deshpande, whose birthday happened to be 3rd September, and it is Malati Mandal, Yoga Yoga, that his oration in his name is happening on Teachers' Day, and that also in September. So let me begin with my topic. Hemangi has taken us to a big academic arena through his professional talk. I will take you to the neuro-OT grounds today. So the topic, as suggested by Pragya, is complications encountered in neurosurgical anesthesia in our day-to-day practice. Can we really avoid them? There are multiple topics which I have incorporated in my talks, and I'll be giving you the practical tips and the reason. Actually, I have faced the problems during my work in neurosurgical anesthesia. The most amongst that is positioning of the patient, which is the key to the success of your neuroanesthetic recovery at the end of the procedure and even in the post-operative period. Now, as we know that neurosurgical position provides operative comfort to the surgeon and optimal access to the brain area. The position poses a lot of problems and complications, but however, it is our duty, that it's a prime concern to prevent them at all cost. There are varied options for the positioning and their modification for the easy surgical access to the neurosurgeon. But at the same time, we must remember, since the patient is anesthetized, there is always an added risk that we may cause some trauma or some complication to him. The patient is not aware of this under anesthesia of his compromised position, and therefore he is not been able to complain. Therefore, take all the care for these patients when you are positioning them. There are very, very common mishaps which can occur during the positioning, which are preventable. But some of the distinct complications or problems are really not preventable. Positioning causes a lot of pain and discomfort to the patient after the recovery, immediate recovery. It may cause delayed recovery, several peripheral nerve injuries and brachial plexus injury. There may be permanent damage to the brain per se, not because of the positioning, but it may enhance, it may per se because of the surgery itself. There may be a lot of changes in the dynamics of the respiratory and cardiovascular systems. And finally, there could be complications due to obstruction of jugular veins, vertebral venous plexus, vertebral carotid arteries, and CSF flow. To this list, you can keep on adding many more as you remember, but these are the important distinct aspects of positioning. What are the principles of positioning? We must know that positioning is not the responsibility of the surgeon or neurosurgeon only. It's a joint responsibility of the anesthesia team as well as the surgical team and the paramedicals available in the operational theatre. The ideal patient positioning involves the balancing act of surgical comfort against the risk that is involved in that particular position for the patient. Therefore, the positioning and the postural compromises should be considered right in the pre-operative checkup and should be thought over that how best you can position this patient for a particular neurological lesion. There are two principles which are involved in giving the ideal position for head and spine surgery. Number one, there's an imaginary trajectory which runs from the highest point of the skull surface area and to the area of the interest in the brain. And this distance should be shortest possible between these 2 points. The second one is that the exposed surface of the skull and the imaginary perimeter of the craniotomy should be parallel to the floor. It is very important to understand that positioning is just not something like that you position the patient and you go away. It's a very dynamic process. We, under anesthesia, during controlled ventilation, the IPPV that we are giving, it interferes with your venous filter, arterial tone, it may change the autoregulatory mechanism. The patient under anesthesia is vulnerable for many circulatory effects of change in position. Blood pressure is often labile immediately after induction of anesthesia and during the position because it's the initiation of the anesthesia and probably your patient has not achieved the adequate level of anesthesia. Therefore, turning the patient on the operating table must be very gradual and there should not be interruption in the monitoring of the patient. As you can see in this diagram, these are the various types of approaches which are taken by the neurosurgeon to access the neurosurgical lesion. Craniotomies are usually done in basic positions like supine, lateral prone, or three-quarter prone position sitting, as well as the spine is also done in prone or lateral position. The variants which are used are actually modifications of these basic positions also, but they are just modified to suit the surgical approach. All these positioning, they need the specific kinds of tools that we will see further. Coming to the physiological changes that occur in the various systems, I have been enlisted in this chart, but I would like to draw your attention, which is very relevant in neuroanesthesia, the mean arterial pressure. You see, this is one of the key parameters that we keep on harping in neuroanesthesia. You see, in all these basic positions also, the mean arterial pressure is on downwards. It goes down. So therefore, we have our aim is that to keep it in the right range so that we are not dealing with the complications of circulatory system. Similarly, in CNS changes, you see the intrapressure pressure is rising in the lateral as well as in the prone position. Contrarily, the supine position gives much better intracranial pressure. It is downward. It is going down. I'm sure that the people in the audience would know the basic modification in the neurosurgical positioning is head and neck positioning, which is very important. The basic positioning causes physiological changes in all these systems, CVS, RS, and CNS, and even in their modifications. However, the position of the head and neck in relation to the rest of the body may have further adverse effect on cerebral dynamics. They may initiate certain complications right at the beginning, which may be detrimental to the patient and for his final outcome. This is a pictorial representation of head and neck positioning that I want to draw your attention. That positioning of the head and neck is an integral part of the neurosurgical positioning, both for the craniotomy as well as the spine surgery. There are three elements which are very important while you are positioning the head and neck, and they are rotation of the head, flexion of the head, and extension of the head and neck. But if a situation comes that these three elements they become culprit, if you don't do it in the right way, they could be culprit and they can cause a lot of damage to the CNS. They may compress the brainstem, cervical cord, causing ischemia, and it may lead to quadriplegia or quadriplegia or cerebral infarct. Therefore, it is very essential to prevent the adverse events and trauma during positioning of the head neck in relation to the rest of the body. One must have the adequate knowledge of the surgical site. One must understand the physiology of that position, and one must keep in mind what are the risk factors with that particular patient while he is maneuvering his head and the neck, like osteophytes, arthritis, and atherosclerosis. As I said, that head and neck position is given by the special equipment like different kinds of clamps or horseshoe, and the head is fixed on the head clamp. Now the clamping gives very good immobility and surgical comfort, but mind you, it is an extremely painful procedure and the most noxious stimuli that you will come across during a neurosurgical anesthesia. This augments a serious response so much that there is a severe tachycardia and hypertension. And this could be very dangerous in the patient who have cerebral aneurysm. There could be possibility during this procedure that the aneurysm may rupture if the tachycardia and hypertension goes beyond control, even for the momentary, even for the few seconds or few minutes. If the frame is not applied, possibly when you are doing it to your junior to receive apply, there could be possibility because of bleeding at the side of pin insertion. It may go inside so much that it may prick the emissary veins or maybe a diploid, and there could be possibility of air embolism. If it is done very hastily, the scalp and eye may bleed, it could cause laceration, and with the prolonged use of this, there could be pressure alopecia at the site of insertion of the pins. So therefore, what is our role in this? That we must take all the precautions to attenuate this response by deepening the level of anesthesia either with the propofol or inhalation agent. Recently, many people are using local infiltration at the site of hissing, but if you need to check the site of hissing pin insertion, the local infiltration may not be effective. It will just slip that side. Therefore, scalp lock is the most effective modality for preventing the causing the attenuation of the response of the pin insertion. Extremely effective, and it also reduces the intraoperative requirement of analgesia if you are use a long-acting local anesthetic for your scapula. Two important things when the head is fixed in the clamp. That when the head is fixed in the clamp and if the patient becomes light in this, because everybody is busy in the position, he has not paid attention to either repeat the dose of relaxant or giving some analgesic, and the patient has become light during this procedure. It is going to be very hazardous. It may cause scalp injury. It may also cause intracranial hematoma or eye injury in the lighter plane of anesthesia when the head clamp is being inserted. Second thing, always remember that before you start reversal or you want to this thing now, remove this thing. It's better that you remove the pins before you start, the patient start attempting or you start your reversal agent and extubation. These are the two reasons, or these are the two distinct complications. They can be easily prevented by giving the additional dose of anesthetic either in IV form or in the inhalation form by using the scalpel. So therefore, during clamping, ensure that you have adequate depth of anesthesia, there is a hemodynamic stability, your oxygenation is going on properly. The preservation of the monitoring process is continued, because if there is any disconnection during the positioning, there could be a total blackout. I mean, don't know really what has happened. It may so happen that something is going wrong here, and then you will not be able to notice that and treat that. Therefore, the ASA task force has come out with certain guidelines, and these guidelines are very useful. If we comply them with totally, I am sure that the majority of the problems and complications we can really get on it easily. Before I go to these guidelines, I just want to recap the distinct problems associated with the different positions in relation to neurosurgery or in relation to the systemic changes. In prone position, there are a lot of cardiovascular changes like change in stroke volume, cardiac output, cardiac index, impedance to ventilation, if the abdomen is not full. There is venous compression, rising CVP, cable compression causes hypotension, and there could be tubular compression with acute neck flexion, which may add to the bulging period. The park bench position is also a modified lateral position. It has a similar distinct effect as your lateral position, but along with that, there could be possibility of brachial plexus injury if the hand is not taken care of, especially the hand which is on the downside. There is a flexion, excessive flexion and rotation may cause danger to the ipsilateral side of the arm and pressure on the upper trunk on the contralateral side. Sitting position that all of us on the first day have been emphasized that it is with lots of distinct complications, very dreaded ones like venous and paradoxical embolism. This is the position where your flexion, hyperextension, all those come into play. So excessive cervical flexion may impede the arterial as well as the venous flow. There may be impedance to the respiratory excursion if it is not being given properly. Now, sometimes recent time people are using TE probe for monitoring the air embolism. If this probe is not properly placed, or if it is very big, it may cause compression of the laryngeal structures and the tongue, and it may cause oral edema. There may be chances of pneumocapillus in sitting position, macroplasia because of the sitting position. If the cord is or the cervical spine is not being taken care of, there could be paraplegia or quadriplegia. And of course, during the surgery, the brainstem manipulations are very, very, very hazardous and taxing to the anesthetist as well as patient and the surgeon, which manifest as a bradycardia and cardiac. So when the patient, when the surgeon is on the near the brainstem area, you have to be extremely vigilant and alert to monitor these changes and stop him if they are worsening with progressive surgery. Coming to the guidelines by the ASA task force, They said that during the PSC, 2 or 3 things have to be noted so that you first identify the at-risk patients for developing the neuropathy. Now, this group of patients consists of the elderly patient, the diabetics for a long time, or the patient who have underlying neuropathy for some other cause. You should counsel your patient regarding a particular position that is to be given to them in surgery and tell him the possible complications, which may be of a very shorter duration or may be of a longer duration. And you ensure that the patient is in a position to comfortably accept the probable surgical position under anesthesia. Document all pre-existing neuropathies because that has medical legal importance. As I said earlier, avoid hyperflexion, hyperextension, and acute rotation of the head and neck. Especially in the C-spine cases, the color that we are putting in to prevent the neck movement should not be very tight. It should be just properly fitting and should not obstruct the venous flow coming from the head. Now, regarding the rotation of the head, the permissible limit is between 0 to 45 degrees. If for the better surgical access, one needs more rotation, it should be done by placing a roll beneath the opposite shoulder and not by really turning the distinct head beyond 45 degrees. During neck flexion, maintain a thyromental distance of at least 2 fingers or at least 3 fingers if somebody is very young and thin between the chin and the chest. I used to always carry out a catheter test right from the beginning of the position to say that the patency of the tube is maintained. That was my personal practice, which I kept on doing till I retired from neurology. Now, wrapping the legs with the elastic wrap bandage to prevent the pooling and stasis of the blood. In good old days, we had no other access or no other stockings and everything available, so we used the simple crepe bandages. These days, now we are available with the intermittent compression systems, which are very helpful to prevent the pooling of the blood and stasis of the blood. In prone position, the coordination of the operating staff, surgeons, anesthetists, and paramedics is very, very important. It's most difficult way to prone the position. Most difficult position, I would say, that to be given. And monitoring of the pulse oximetry and BP is extremely vital. We are making the patient prone. Regarding the supine position, the crucial point is the position of the hands. The hands should not be extremely abducted, not more than 90 degrees. The neutral forearm position is recommended and it is safe. So therefore, either you tuck the arms at the side of the patient, or if the patient is too bulky to be kept on the to be tucked on the side, you can keep them safely on the arm wall. You can see in these diagrams I have highlighted them. Now, stretching and compression of the hands may cause several neurological deficit and injuries to median down and rear limb. So one has to be really careful while giving the supine position also, although one thinks that it's the most easiest position, it is not so. As far as lower extremity is concerned, the stress is given for avoiding the prolonged pressure on below the buttocks, below the knees, and even the thighs and at the footrest, because the possibility of the peroneal and sciatic nerve injury or neuropraxia is very common. So these days, you either give it by the soft padding with the cotton, or these days there are some paddings are available with some materials which are this a lot of distal pressure support to the soft tissue. Monitoring of the ICP is done many times in many setups. So while doing the ICP and CVT monitor, it's a good monitoring, and it's very helpful to guide your position and give you the fair idea about the hemodynamic changes which are occurring during position. Proper padding of the potential compression site for the adequate protection of the nerves and the vessels is very important. These diagrams are showing the various compression points, and it is mandatory that before you finalize and you tap the patient to the table, that you have taken care of all the distinct paddings and you have given the support to joints and the areas where the nerves and major vessels are present. Avoiding the abdominal and femoral compression is also very important in prone position to facilitate venous return and to decrease the surgical bleeding. The prone position, if it is unobstructed, it favors the expression of diaphragm and it increases the ventilation and oxygenation. So as I see that you can see in these diagrams this thing, enough amount of space is given between the chest and the sternum down to the distinct pelvic support. Monitoring of invasive line is important not only in the prone position according to me, but in majority of the distinct neurosurgical cases, and especially in the patients who have either serious or ALS comorbidities or the trauma patient, because continuous monitoring of the vital parameters is extremely important. They give a lot of information not only about the systemic hemodynamics, but much more about the neural CNS dynamics also. The lateral position requires an axillary roll to be placed under the upper chest or in the axilla to avoid compression of vital structures like brachial plexus and axillary artery. Now, at the end of giving this position, you should see that the level of the head should be above the distal, the heart, to improve the venous drainage. So, a 15 to 20 degree tilt is always recommended, and it should be given very slowly, not very abruptly. Finally, whatever you are doing intraoperatively, the positioning wise, you should document the specific position, the changes that have occurred during any calamities that have occurred during the position, because they may have a direct impact on the post-operative outcome. And it also, this thing is helpful to check the functional integrity of the potential neuropathies in the post-operative. It also helps you to refine your techniques with the data that you collect from each patient. So therefore, at the end, I would say that one must know the physiological alterations with different positions and the intervention to prevent and treat the complication. This will help you to predict the potential problems, improve the outcome with decreased morbidity and mortality. So that's the end of the disease positioning. Going to the second topic. This topic is specifically, I have named airway difficulties and neurosurgical patient, but not the difficult airway, because difficult airway could be part of these difficulties. So what are the airway issues in neurosurgical patients? There are various challenges of different types. You may have a patient in whom you have anticipated the difficult airway. You may have a patient you may have not anticipated. You are an unanticipated patient with a difficult airway, and you are not prepared at all to take care of it. There may be a potential post-operative airway-related risk due to neurosurgical procedure. There are so many other challenges and considerations are there in neurosurgical patient, and there are certain unique challenges. So let's see one by one. The patient in whom the difficult airway. Who are these patients? These patients are acute cervical spine injury with instability and immobilization, or the patient whose head is fixed either in a hollow frame or stereotactic frame, or the patient with the condition for the high incidence of difficult airway management or with the failed intubation earlier. Patient with a pituitary surgery, chronic spine disease with myelopathy, occipital cervical or cervical fusion, or patient for the temporal neurosurgical procedure done earlier, coming second or third time. Patient for the functional neurosurgery in whom the awake sleep craniectomy procedure or spine procedures are done. embolization procedure, and pediatric repercussion with congenital like craniofacial dysmorphism, spinal dysmorphism, congenital hypothalamus. Now coming to unanticipated difficult wear. What is so great about it? If you are unprepared and you are unanticipated a situation, it could pose you a greater challenge in patient with the risk of cerebral aneurysm, fatal fracture, or the patient who are just on the brink of brain herniation, it may worsen. Or in head injury patient, they may worsen and their insult, secondary insult may worsen further, causing morbid outcome. You may have a patient in whom you are undetected the myelopathy, second is the chronic cervical disease, and you may cause this thing severe hyperextension, hyperflexion, or movement of the neck, and at the end of it, they may land up with some nerve injuries. The other challenges is that we are always worried about the patency of the airway because the positions are unusual than the other surgeries. And therefore, right from the intubation, maintaining the patency during the intraoperative period, extubation, and even in the post-operative, the patency of the airway and neurosurgical patient is extremely important. Therefore, you all the time in your mind whether my tube is all right or not. So see that your tube is properly fixed, the tube is not kinking, there is unobstructed airway, the airway pressures are not rising. Check that time and again several times. It doesn't matter if somebody laughs at you, you are not confident, but it doesn't matter. Make that protocol. You keep on checking the patency of the airway. Every step that you do position, every step the surgeon is doing something, every step that you have any doubt about your airway pressure. Now, sometimes extubation in patients after prolonged surgery is difficult. So you have to have a particular strategy of extubating these patients. That could be a really challenging in the post-operative period. Some patients may have a peculiar sensitivity to some narcotics because they have some nervous system disease and hypnotic, especially the hypnotic agents. Therefore, that may be the cause of concern in your post-operative patient, that whether these patients may lose the airway once they have been extubated. A unique challenge in all kinds of neurosurgery, whether you are anticipated difficult airway, anticipated whatever it is, unique challenge in each and every neurosurgery patient is intracranial dynamics and airway. Now, as we know that presence of intracranial hypertension or limited intracranial compliance is extremely important, and therefore quick and smooth intubation is the key to the success and prevent further insult to these patients. So while achieving, maintaining and rescuing the airway process, we need to see that there is a balance and maintenance of CNS hemodynamic in terms of cerebral blood flow, blood volume, and CSF dynamics. There is avoidance of raised ICP. There is maintenance of cerebral and spinal perfusion. The primary goal is that the patient may be compromised with the CNS dynamic right in the beginning, and therefore avoiding further rise in the ICP to prevent the further neurological injury is extremely important. Therefore, be careful because we are doing certain procedures like laryngoscopy, intubation, and these may result in the acute rise in the ICP and the heart pressure. Movement at the craniocervical junction is really undesirable, and one should be very, very cautious about these movements of neck during the laryngoscopy if the patient has some history of neck problem. Airway obstruction, difficult bag and mask ventilation may quickly lead to hypercarbia, hypoxemia, increased CVF, and aggravating the intracranial hyperthermia. Therefore, history of these difficulties should be noted and they should be remembered, whoever is doing the intubation in these patients. Now, what can we do about this? So, I have always made a definite statement that I always used to assume that there is some potential risk of airway difficulty during the process of intubation maintaining the patency of airway throughout the position, and the surgery and during the extubation of neurosurgical patient. Therefore, the assessment of airway by various methods, not just by Manampatti, is adequate. Sometimes it's more than that, some distances. But then whatever methods are available, one should really apply them and come to the conclusion that the airway is really difficult or it is not difficult. There are various diagnostic tools are available these days. So you must take help of these diagnostic tools if required. And you should not shy away asking the distinct surgeon to do a particular test for assessment of your airway. Keep as many as possible airway securing tools in readiness. You don't know that which may come to your rescue during the difficulty. Be ready with the alternate plan of intubation technique. If one fails, the other is ready. And always have a good assistance during laryngoscopy and intubation. So let's go to assessment of these problems. Now, what are the assessment strategies? That you have written history, examination with test and scores. The particular attention must be given for the previous history of difficult airway, mask ventilation, laryngoscopy, intubation, as I said earlier. The special attention should be given during prospective intubation and surgery, but also in the perioperative period if there are signs and symptoms of ventricular vascular insufficiency in a particular patient. Find out whether they have any syncopal attacks which are repeated that suggest there is a vertebral-basilar insufficiency, very beautifully described as Post-operative stroke syndrome or adolescent stress syndrome. Whether the patient had any transient ischemic attack TIA or any stroke which recovered, any presence of carotid fluid. In this table, I have tried to show what are the assessment activities we usually undertake, so I will not go into details of that. The other strategy is that beyond your test and these things scoring systems, you may have to have a plain radiograph of neck. You may have to do CT scan, MRI, angiogram. Normally, these imaging modalities are already done in these patients. I used to always request my radiologist to have a little bigger cut extending up to the airway so that I can easily assess any problem in the airway of that particular patient. It may give you valuable information about the patient airway as well as it can tell you about what is the intracranial status of the signs of increased ICP, presence of hemorrhage, infarct, disease pattern, or edema. For difficult airway suspect in an extensive skull-based pathology, preoperative endoscopic airway assessment is very, very useful. Also, the airway USG guided assessment is an adjunctive assessment, is a very good adjunct to approach our airway related decision making. I'm sure that you will all agree that in clinical practice, unexpected difficulties may occur in about 25 to 30% cases. Approximately 50% of them are pseudo-defective cases. That is because unskilled operator, incorrect execution of the maneuvers, or lack of working guidelines or protocol. The limitation, we know that there are several bedside tests, screening tests are there, but there are certain limitations of these tests to assess difficult airway. And therefore, you have to take the assistance of various diagnostic tools that I described earlier. It is important to predict the difficult airway by various tools and various scale that have been described, but it is important to know how to do, what to do afterwards and how to do it. I would go and describe the specific problems in various few of the lesions which are important in surgery. Let's come to the head injury first. Now, with improper technique in head injury patient, there could be possibility of worsening the secondary injury. It can progress or it can worsen. If improperly planned airway technique, can severely compromise the intracranial dynamics and it will increase the morbidity and mortality. Now, what are the predictor of mortality in these patients, those who are brain injured, like hypoxia, hypercarbia, hypertension, intracranial hypertension, and hypothermia. Therefore, we must take the adequate precaution. Our technique should minimize least amount of head movement in head injury. There should be always a concern about the cervical injury, and it should never take a precedence over the relieving hypoxia. Ensure appropriate amount of airway maneuvers if it is of a critical importance. Now, caution should be exercised in putting in blindly certain devices in the nasal cavity in the hope of helping the patient, and especially in the patient who have got basilar skull fractures or sinus injuries, and putting in a nasal tube for airway control, or putting a nasogastric for decompression of the stomach, or Foley's catheter to control the massive epistaxis. In cervical spine injury, manual inline immobilization is good enough, but do not give any traction. Immobilization of the head between the two sandbags is a very simple and the best method. But if you try and do the intubation with a rigid cervical collar or on the spinal board, it may increase your difficulty. It may make the intubation difficult. There could be a risk of aspiration. The cervical collar does not necessarily protect the movement at occipito-cervical or cervical-thoracic junction. So keep it in mind that manual inline mobilization is the best technique to prevent the movement of cervical spine in the cervical spine injury. Now, various modalities have been used. They may be of a different sensitivity to clear the airway of cervical spine injury. First, we have clinical evaluation, brain X-ray, CT, MRI. You may use the dynamic fluoroscopy. This is readily available in the neurosurgical operation theatre and pharmacia. Now, why I'm saying is this, that in the conventional laryngoscopy, we are causing a lot of movement and they may be potentially dangerous. If you see the effect on direct laryngoscopy by lateral blade, we will see that there is a lot of this thing action at atlanto-occipitally and atlanto-axial joint, and which is the most significant movement. Even your chin lift that you will give for maintaining the distal jaw fit, it is of a greater movement than the intubation itself. So take care of these two movements while doing the laryngoscopy. Airway in the cervical spine diseases, chronic diseases, especially the patients with the ankylosing spondylitis, rheumatoid arthritis, Kuprinkel syndrome, or the fused cervical vertebra, the direct laryngoscopy may not be possible with this patient. They have a difficulty to assume the sniffing position, and therefore you should have the alternative methodology to intubate these patients. The airway in the awake situation, the hollow frame given for the head neck fixation, which may prevent the proper position for laryngoscopy if we need to intubate the patient, and restricting the atlanto-occipital extension. Now, during the functional neurosurgery, for resection of the regions at eloquent area, the patient is usually awake or under mild sedation. But if the patient becomes restless and agitated, and if you keep on giving sedation, there may be possibility of loss of airway, and that may come to a situation of emergent securing of the airway. Therefore, even in these patients, you should have the complete regimen or complete protocol of assessment of airway and readiness to intubate this patient by whichever method that you plan at that point of time. Awake craniotomy, that is asleep, awake, asleep. But if there's an over sedation, again there is a possibility of loss of airway. Embolization procedure or coiling procedure done in the DSA suite. There are two most potential complications are there. There may be cerebral infarct or hemorrhage. and that way also avoiding the emergent. Coming to the acromegaly, we know that the acromegaly gives a lot of distinct problems as from head to toe and knee to head, and there may be a difficult airway due to many factors in acromegaly. There may be problematic mask ventilation, there may be upper airway obstruction, or the patient may have sleep apnea, obstructive type of ventilation. The other problem with these patients that these patients are usually subjected to transcanal section through nose. Therefore, at the end of the surgery, there is a bilateral nasal packing, which gives breathing problem. If the patient is not counseled preoperatively and has not been trained to breathe through audit cavity, the patient may become aggressive, agitated, and you may have to secure some way to, and he may just not breathe by the audit cavity. And to worsen your situation, you need to secure the airway, which is earlier difficult anyway. There are some distinct cases which have been described in whom the negative pressure edema has been described in acromegaly patient. So keep that in the back of your mind. And this happens because of the partial obstruction after the extubation. The one most and very dreaded situation that can occur, that as soon as the patient is handed over to you for oral toilet or for plan of extubation or maybe plan of change of tube, the oral cavity has to be studded with this blood which comes from the postoperative wall. So you have to be very careful in removing all those blood with a very good lavage to the oral cavity form saline. One word of caution: sometimes you may remove all the clots and see that your airway around the distal tube is clear, but one clot which sits behind the distal palate, that is coronus clot, will dislodge later on. And we said, okay, patient is fine, we can extubate, he's awake, and there's no need to intubate him or ventilate him or to the tube for longer time. At that point in time, this coronus clot will get dislodged and suddenly cause airway obstruction. So one has to be very careful, or maybe go behind the renal and see whether the area is very clear and there is no clot. Pediatric patients and genital anomalies, a lot of difficulties are there. There are always some anatomical physiological changes with this congenital anomalies. There could be sleep apnea because of the mid-face protrusion. There could be atlanto-occipital joints instability, coexisting comorbidities of cardiac, pulmonary, or renal or metabolic nature. There may be neurological dysfunction and increased ICD. These patients are usually presented to us with various corrective surgery, remodeling surgery, PM joints, ankylosis, occipital cervical fusion, or even for that matter, hydrocephalus, simply a very day-to-day disease surgery, and maybe meningomyelitis at the other sites. So keep in mind that they may have this anomalies, they may have the airway problem because of their congenital problem, or they may have the systemic problems which may worsen during your induction and during the problem. Now, airway in the post-operative period, what are the risks? In post-operative period, there could be occupation of the airway, and the cases in whom it is more possible, this patient with the history of seizure, patient may have the distinct convulsion immediately after the distinct extubation. So see that the patient is 90 distinct loaded, or rather I would say that given with those of anticonvulsant intraoperative period and just before the extubation. The patient who are likely to have herniation, like your Platyvasia patient, a patient who already has some tonsillar downward shift, patient with the infarct or bleed or cerebral edema. As an anesthetist, you should remember there could be some residual effect of the anesthetic drugs, which may cause hypoxia or hypothermia, intraoperative acid-based fluid and respiratory problems, or merely the surgery-related airway injuries. And there are certain position-related problems. Therefore, you have to plan your extubation properly. And there are few of these important points to be considered in this kind of surgery. In supratentorial surgery, especially through your temporal incision or perianal craniotomy, if these patients are repeatedly coming for the repeat surgery, this patient may suffer some kind of mouth opening or eating problems because of the severe scarring of the temporalis muscle. They may have this difficulty in mouth opening on subsequent occasions. So remember that when these patients come for the repeat surgery, they have not developed the restriction of the mouth opening. Cervical spine surgery, there could be upper airway edema due to the surgical retraction. There could be laryngeal nerve injury because of the angioedema or hematoma formation, which may come as late as second or third week. This may, there could be number of distinct cervical levels are manipulated, therefore it is indicated to distinct sort of post-operative ventilated patient or do late extubation. Very higher levels of cervical spine is being operated like C2 or C3, or if there's a long duration excision, or if there's a later intraoperative blood loss. So you may have difficulty in these patients because of these reasons. Again, there could be migration of bone or the synthetic graft on the plate that has been fixed in the cervical spine. It will migrate and obstruct the airway, compromising the airway and cause acute emergency. These patients may have swallowing difficulty and dysphonia, and they may have this sleeping position during the direct laryngoscopy. So if they have to be reintubated post-operatively or respiratory compromised, you will have to have equipment like video laryngoscope, you have to have optical stimulation, intubating standard. Certain surgery-related problems because of the positioning of the real positioning, lower cranial nerves in relation to the posterior prefrontal, the patient's ability to maintain the airway may become compromised post-operatively. Because of the proximity of the brainstem, further hazards they are presented post-operatively in terms of respiratory problems. Patient may stop breathing, or paradoxical breathing, or apnea. Certain intraoperative position-related problems may cause facial edema, macroglacia, oropharyngeal edema, or there may be spinal cord infarction due to sitting position, quadriplegia, and it can compromise. All these positions may compromise the airway. Nonetheless, that you have very heavy patients for intubation, you do not have per se the intubating compromise, the difficult airway, but their heaviness, especially between big breath coming in your way to intubate at first shot or intubating. So, what are the reminders of maintaining the patency of airway? The art of intubation should not be surrendered to the technology, but it should be aided for understanding. One should understand the basic anatomical difference of the airway, image and medication, the physiology of the position that you have, the pathophysiology of the disease in relation to the consequence of airway management, the appropriate uses of the basic airway devices and even the distinct modalities, and what is the influence of neurosurgical procedure on airway. The airway technology must not replace the good planning and management approach for every difficult airway scenario. Learning the basic airway technique takes time. It is a process, it demands mastery. It is an art, and therefore it must not be replaced by the technology. Instead, it should be aided by it. There are no shortcuts. We cannot break the rules once we have mastered them. So, skill and technology of the airway management must go hand in hand and should not be replaced. So, when sometimes one anticipates a difficult airway, sometimes one experiences difficult airway. So, therefore, always anticipate access and access. Am I audible?
Yes, ma'am. Yeah.
Coming to the hemodynamic stability, why it is important. The systemic hemodynamic parameters can be measured, monitored, but the cerebral hemodynamics cannot be measured, monitored easily and directly. So usually we derive the conclusion or the values of these parameters from our systemic parameters. The CNS dynamic, it's an interaction between the cerebral blood flow, volume, CPP, CMRT, and ICP, and it is an interplay of systemic, neurogenic, and cardiogenic factor which control these dynamics. Therefore, systemic hemodynamic stability is of crucial importance to us to maintain the well-being of brain as well as the spinal cord. Now, hemodynamic instability is usually seen in neurological region, systemic comorbidities, drug-using anesthesia, anesthetic maneuvers, neurosurgical positioning, intraoperative stimuli of various cranial nerves, and during the operative stroke like aneurysm rupture. Now, it is important objective of neuroanesthesia is to maintain adequate cerebral perfusion to prevent any secondary injury to brain as well as the spinal cord. Therefore, hemodynamic stability is often seen as changes in the arterial pressure and heart rate, intraoperative and post-operative. As we know that hypertension may decrease the cerebral blood flow, causing ischemia, hypertension may raise the CPF, and may cause cyclic edema and even the hemorrhage. I have listed the causes of hypertension in common causes and neurosurgical causes. The common causes, of course, we can take care of very easily, but there are neurosurgical causes like raised aspirating, reduced handling, reduced hypertension, reduced spasm, carotid hypertrophy, autonomic dysfunction. These causes or these elements are difficult to control, whereas those which are occurring under anesthesia, we can control them very easily with the proper and timely intervention. Hypertension, of course, common during the anesthetic procedure can be controlled very easily, whereas the neurosurgical causes like neurogenic stimuli, cardiac spinal shock, carotid body stimulation, emotional handling, repetitive failure, these are difficult to control. Now coming to rhythm, heart rate change, bradycardia and tachycardia. The avoidable causes, of course, we can take care of by pre-operatively treating them, optimizing them. Whereas it is difficult to sustain avoid these changes when there is a pushing reflex, brain strain, or TCR, radio stimulation, or autonomic dysfunction. Same to the tachycardia. It is difficult to avoid when there is a brain handling or when there is an untreated hyperthyroidism. Now, what are the intraoperative stimuli which are responsible for the tachycardia, bradycardia, and hypertension? One is the brainstem handling, passive blood loss, trigeminal cardiac reflex, radial stimulation. And one important thing which usually goes unnoticed, that is negative pressure applied to the vacuum device, connect to the drain in the external space at the end of the surgery, may cause a sudden decrease in the ICP. I just want to draw your attention that this has happened and I have noticed this. So if you are working with a neurosurgical profession, do keep attention to this particular procedure. Hypertension, and what is the key question in the hypertension? We know that cerebral blood flow has to be kept constant and the water deviation, CVF is constant between 45 to 60 ml per minute. Autoregulatory range is between 50 to 150 milliliters of MAP. The CPP equation is MAP minus the ICP, and if it is negligible or very minimal, then the CPP is almost equal to the inadequate when the ICP is normal. Therefore, for all practical purposes, the main arterial pressure becomes our main key of handling the human animals during anesthesia. Remember, therefore, all the efforts must be taken to keep the map at least at 70 millimeters of mercury to help maintain the cerebral blood flow and sleep. Anything below 50 millimeters MAC, below 50 is progressively is passively dependent with the maximum vasodilatation, and anything above 50 millimeters, it may cause the rise in intraoperative pressures and rise in the distinct blood volume, and it may cause hyperemia. This will lead to the cerebral vascular volume and disruption of the brain barrier, especially in the head images, and overgrowing tumors. Therefore, MAP is extremely important. Remember that it is extremely important. It may result in cerebral swelling and hemorrhage. It may lead to malignant hypertension syndrome. It may impair the autoregulation of the injury. And as I said earlier, MAP is a key to the neuroprotective in the clinical setting. So, what to do? So, therefore, as an anesthetist, maintain your MAP by judicious use of beta blockers, alpha-agonist, narcotic, sedative, and as a pre-medication, and intraoperative. Of course, very judiciously and always attending by the anesthetist. The patient is not left alone in the operating room or in the side room when these patients are given these drugs. Consider preemptive anesthesia in terms of strangler or reducing the pain management. Avoid fluid overload or deficit. Fluids to be guided by the blood pressure or CVP. Maintenance of and monitoring of proper depth of anesthesia. Inhalation and Cuba technique. The prevention of hypercarbia, the problems which are coming in your listening territory is thinking of the tube, change airway pressure, use fresh soda lime, and change its timing. Follow the guidelines for the positioning. Search for any different cause and treat it adequately. Always inform the surgeon that something is going wrong. Let's wait and help. And the cushion reflex is usually a protective mechanism, and therefore BP rise during this reflex is to maintain the CTP. Therefore, measure to treat blood pressure should not be taken. Rather, take the use it to reduce the intracranial pressure. Now, emergent hypertension is seen during the extubation. Therefore, it is necessary sometimes to deepen the brain of anesthesia with a short dose of maybe a propofol or some other drug. Maybe you can give a short acting beta blocker like Cerebral to prevent emergent hypertension. Hypertension, of course, can be treated with intravascular volume, and it happens if there is an overdose of osmotic diuresis, inadequate fluid intake due to the altered sensorium, drug-induced during induction and maintenance, or bleeding during the craniotomy itself or in the because of the surgical reason. So, take appropriate measure to treat this and correct the hypertension. Patient with the hypertensive antihypertensive treatment should not be continued with the same drug on the day of surgery, especially with they should be stopped. Or you may convert them to some other drug 3 or 4 days before to shoot their BP level. So preloading of these patients is required, careful titration of the drug, timely placement of the blood and fluid, avoid long-acting hypertension on your surgery, judicious use of osmotic agent. So that was about the hypertension, bradycardia, tachycardia. But there are certain rhythm abnormalities which are being seen, and there is a close association between the brain and heart, which makes the heart vulnerable during the neurological inside. You may have changes right from sinus tachycardia to systolic. The common abnormalities that you will come across will be either rhythm changes or there may be change in morphology of these cerebral forms. The morphological changes that commonly seen, they are isolated P wave, Q wave, U wave, or T wave, or Florex complex or stability changes. Rhythm changes are usually benign and they subside by themselves, such as bradycardia and tachycardia. But if they get converted into dangerous arrhythmias, we will have to take appropriate treatment. The rhythm abnormalities with neurosurgical reasons are usually seen as subarachnoid hemorrhage, traumatic brain injury, brain tumor, stroke, and spinal cord injury. Whereas the preventable and critically caused as an anesthesia, we should remember these are the causes, and we must treat them timely to the appropriate drug regimen. Prevention. There are certain pathological conditions may not be preventable. Some of the conditions may be easily controlled in order to avoid the occurrence of these changes. And these are correct the electrolyte imbalance, avoid hemodynamic fluctuation, avoid hyperventilation, use it cautiously and for short term, avoid the factors that may cause ICP, or minimize the use of drugs such as paclitaxel or hydrogen peroxide. The surgeon may need to use the Intraoperative. So that was all about the hemodynamic stability. Coming to a short discussion about the brain edema. Before I go to brain edema, there is a newer concept about the brain relaxation. We usually talk about the swollen right brain or brain edema or increased ICP. The surgeons are always seen shouting, the brain is trying, the brain is coming out. And then it's a very taxing situation for the anesthetist to control this situation. Therefore, we have to take enough precautions pre-operatively or intraoperatively so that the brain is relaxed. In 1962, Gayes and Scullin proposed the concept of brain relaxation. Now, what is the brain relaxation concept? It's a clinical entity that the anesthetic, surgical, and physiological and the outcome implications are related. It describes the relationship between the volume of the intracranial content and the capacity of the intracranial space when the cranium and dura are opened by the neurosurgeon. This concept is available only when the cranium is open and the content-space relationship can be assessed directly. So, why brain relaxation is so important aspect of anesthesia care? Because it is required to improve the surgeon's operating condition for the good access to the region, to minimize the severity of refraction injury and ischemia, and for better surgical outcome. Coming to the brain edema. Before that, I would like to just remind you of the neurophysiology. Brain has a rigid box, cranium is a rigid box, has three content. Majority of it is brain tissue, 12% of blood, and 8% of CSF. These three contents, when they are in normality, they keep the intracranial pressure between either 10 millimeters or mercury or less than that. But if any one of these components is increased, then there are compensatory mechanisms which is described by the Monroe-Cleave blood flow. The first to decrease is the total blood flow, primarily the venous, which is followed by displacement of spinal cord or spinal spaces. It is further decreased by CSF production. There is early exhaustion of the initial compensatory mechanism, and further increase in volume of intracranial component will lead to the rising ICP. So, this rising ICP may contribute to a brain edema. It means there is excess oxidation of water in the extra and intracranial component because of the shift of this water from one compartment to the other. This is the curve which shows the relation between the rising ICP, intracranial volume, and the ischemia that sets in slowly over the period of time. As I said, brain edema means excessive accumulation of water in the extra or interstitial compartment. Increase in any component is compensated by reduction displacement, as I said earlier. As we have three components, there are three anatomical compartments also. And what are these three anatomical compartments which can give rise to excessive fluid accumulation? One is cellular component, which contains neuron supporting cells, extracellular component, which is interstitial tissue and CSF spaces, and vascular component, with arteries, capillaries, and veins, which holds the intracranial blood. The volume expansion of any one of these or any more than one can cause engorgement of the brain tissue and cause brain swelling. This table describes the types of edema that we observe: vasogenic edema, cytotoxic edema, interstitial edema. What we see normally is a vasogenic edema shift from intravascular to extravascular state, cytotoxic edema, extracellular to intracellular. What we normally get to see is a vasogenic edema, usually in the head injuries. Cytotoxic edema is usually any inhalation of toxic materials which can give rise to cytotoxic edema. Hyperemic edema is usually rising the intravascular volume in the arteries, veins, or sinuses. If the tension between the cranial cavity is very high, the brain may bulge along the fever matter, even if the fever is open. So, secondly, the ICP is not working or the ICP is not relevant once the data is open. So the term ICP is not to be used once the neurosurgeon has opened the data, the brain is directly exposed to the hospital. It is considered as zero. So these are the different ways to describe the compartment edema. These are the causes where the distinct edema. Neurosurgical patients can be preoperatively existing, and that cannot be easily or very immediately treated, like infections, trauma, influence, stroke, exposure to certain toxin, and vasculosis, severe electrolyte imbalance because of the neurosurgical reason, and hypertension, or very rarely high altitude sickness. So, what are the distinct surgical factors which may cause brain edema and which could be very acute? That is excessive intraoperative handling of the tissue, coagulation of the veins, and excessive brain handling causes edema. Now, the preventable causes of brain swelling. Intraoperatively, brain relaxation may be at jeopardy due to brain swelling or bulging to the cranial cavity. The common causes: compression of the neck vein, excessive flexion, rotation, or those things. And these are the common causes that I have already described: thinking of the two, bronchospasm, and the pneumothorax, compression of chest and abdomen in position, right up plane of anesthesia, venous air embolism, or there may be a sudden acute rise in heart rate or BP, rapid hyperdynamic service. This may all lead to brain swelling during surgery. So, if they are taken care of at right time, or if they are taking a preventable measure, we can really prevent the brain swelling because of these diseases. How do we diagnose the brain swelling usually? One by clinical signs and symptoms, and preoperative, maybe by radiological findings, the CT scan, MRI scan. The CT scan will always show the decreased density, and it appears like a dark image in the CT. MRI will show your decrease in intensity and even multiple, or an area of increasing in 5 and 2. Vasogenic edema is primarily involves the white matter of the brain. The CT scan will indicate decreased density on CT, and the MRI will show the decreased intensity of white matter and projection interposed between the normal brain. Cytotoxic edema involves both gray and white matter. So therefore, there is a decreased density and decreased intensity of the matter. What are the treatment options? Promptly recognize the cause and the clinical entity. Institute the targeted therapies is very vital. Efforts to preserve the neurologic function. Assure satisfactory clinical outcome and prevent the mortality. Brain edema always disrupt all these parameters of cerebral hemodynamic health. ICP, cerebral blood flow, inadequate oxygen delivery, energy failure, and further increasing the edema. The important goal is to interrupt this vicious cycle. And therefore, the treatment modalities are divided into various general measures and specific measures depending on the cause. The general measures is that we optimize the cerebral perfusion, oxygenation, the osmotic gradient, venous drainage, minimize the cerebral metabolic demand, and this may limit this thing, the increase rise in cerebral edema to some extent. But like these are the clinical visiting maneuvers like head elevation, optimizing the neck position by various measures, avoid jugular compression, avoid improvement of venous drainage, avoid jugular venous contraction by avoiding flexion and rotation, give a head elevation of 30 degrees. Ventilation and oxygen, avoid hypoxia, hypercarbia, intubate and ventilate the head injury patient if there is a low distress of poor airway reflexes or the patient has aspirated, patient that is fluff on the or pulmonary edema. The PaO2 should be maintained to 100 millimeters and PCO2 around 35 millimeters. Regarding PEEG, they say it is may require to improve the oxygenation, but it may adversely affect the cerebral venous outflow and prevent this cerebral edema and ICP. Therefore, one has to be careful while taking the decision of instituting PEEG. Maintaining CPP, for that you have to maintain either normal pneumonia with adequate amount of aspiratory fluids. Maintain the CPP greater than 60 milliliters with adequate fluids. If not, then you will have to do basic residue required. I avoid the use of hypertension or systemic dehydration preoperatively. Management of hyperglycemia is also important because hypoglycemia as well as hyperglycemia is both they are hazardous to neurosurgical outcome in their own account. If the patient has preoperative and epiphysis emergency surgery, you have to take all the precautions to maintain a normal thermal. If you observe that the temperature is rising for some reason, then you may have to take surface cooling during the intraoperative period to control the body temperature. Seizure prophylaxis has to be given to the patient who has a history of convulsions preoperatively. But as a prophylactically, even empirically, its use is questionable. There may be subclinical seizure activity that may worsen the edema. Therefore, definite evidence of seizure is there preoperatively. You have to load the patient with anticonvulsant preoperatively. Nutritional support for maintaining the nutritional support for maintaining the nutrition of the injury. Free water intake should be avoided, which may cause hyperosmolar state and worsen the edema. Enteral nutrition is preferred unless it is contraindicated. Specific measures like hyperventilation, osmotherapy, reparative steroids, anti-inflammatory, antihypertensive, pharmacological treatment, anesthesia suggestion, therapeutic catheter, very quickly. Remember that hyperventilation is one of the good old method, but it should be used only as a short-term therapeutic intervention as a rescue measure, and it should not be continued beyond 24 hours, because at the end of 10 to 24 hours, there is a fatigue of the hyperventilation, there is a vasoconstriction, it can goes away, and the vasculatures turn dilated. There could be a rebound edema. So remember, it has to be done strictly not beyond the 24 hours until in more definitive therapies are under. Mannitol hypertonic salines are recommended across region because they create osmotic gradient and shift of water from shift to vasculature. 20% mannitol, stable solution, long duration of action, as for almost 6 hours. Dose 0.25 to 1.5 milligram per patient. IV slowly. Timing of mannitol is extremely important intraoperatively. It should be given in such a time that by the time the device the brain is the mannitol has acted, the brain is nicely perceptive and without any disease. So time your mannitol therapy right in this thing. I used to always give mannitol when they used to start the scalp opening, end of the scalp opening, and before they start burning. So that there is enough time of 30 minutes wherein mannitol can be given over to 20 to 25 minutes, and the mannitol is active in the issue. Hypertonic saline is used by many. It is used in various concentrations. The commonly used concentration is about 2%. This increases serum concentration and serum osmolality around 300 to 320 milliosmoles. It should be given by acidity level -1 and to maintain the normal volume. Mannitol given repeatedly may cause hypertension, hyperkalemia, renal insufficiency, and may be sometimes community. Whereas hypertonic saline is cause metabolic acidosis, hyperkalemia, anemia, and it may cause renal damage. Now, rapid correction with the hypertonic saline is known to cause myelinosis, which is been reported in literature reviews. Glutationic fusimide not given commonly given alone, it is usually combined with the mannitol. But this combination produces profound diuresis, using depletion. One has to be very careful combining these two together. Fusimide has no direct effect on the brain tissue, but it just reduces the optical brain. This is very to reduce this. Steroid has definite role in vasogenic edema. Usually dexamethasone in the dose of 8 to 52 milligrams preferred because it has low, the word is wrong, low mineralocorticoid activity, and is primarily given in the hybrid blood and however, it is less effective in the infection, to replace infection, and push up the cerebral. Antibiotic infusion should be given in the patient who are complaining of pain or maybe other analgesic in the post-operative. Patients who are on the antihypertensive should be continued with the antihypertensive treatment because that will reduce the incidence of incident edema if you control the systemic blood pressure. For a short-term treatment, we may use drugs like bisphenol, labetalol, or anabolide. To avoid the potent vasodilator like nitroglycerin and nitroglycerin because they exacerbate the cerebral edema. Vasodilatation of cerebral vessels. Along with that, analgesics, sedative, and relaxing have to be taken care of because they may also contribute in various ways to increase the brain edema as we see earlier. In intractable cases, we have to resort to the perioperative dream to reduce the edema CSA. In intractable edema, pharmacological coma has been advocated as being done in very few and selected cases, and because it has its own hazard, these drugs they act by reducing the cerebral metabolism. Coupled reduction in cerebral CBU, barbiturate commonly used, feeling pentatone has been very hazardous. So pentobarbital being used by many in the dose of 3 to 10 milligrams per patient infusion. Titrated to achieve the most suppression used or for sustained reduction. Propofol these days has been used. Short-acting drug, anticonvulsant property, decreases certain metabolic rate, reduces ICP. The main disadvantage is hypertension. If you give higher dose for longer period, they may be threat of propofol infusion syndrome, manifested as variant acidosis. Hypertension. A word of caution: those who are using propofol drips in the operative period. It is mandatory to check your acid-base tablets while you use. I have come across that face this particular problem in my own pathology, where the patient delayed with acidosis. We thought the acid-base violence in this patient is not done reduces this patient. But at the end of it, when they delayed recovery, we cannot acidosis. So, learning lesson that one has to be carefully titrate before you use propofol as infusion or cerebral depression. Therapeutic hypothermia is also questionable. It reduces the free radical production inflammation. So, many a time comes really to college, the decompressive pneumotomy may be undertaken to accommodate the swelling brain, or they may not keep the bone flap at the end of the surgery because the brain is swollen, so that they just close the dura with the pain vascular, just keep the patient, and then do the distal Thank you very much for this. We'll go to the next topic. Under this heading, I have just a minute. Sip of water. Am I audible? Am I audible? Yeah. Yes.
The laptop.
The break was what? Pardon?
Closer to your laptop.
Yeah.
And the background sound should not be there. That's all.
Sorry, I can't hear you. Anyway, going to hypothermia. Mild hypothermia may prevent or reduce neurological injury, reduce the metabolic rate, induce hypothermia in cerebral vascular procedure, especially aneurysm and urium, but questionable role. But it can occur inadvertently due to your cold fluids, low ambient subclinic temperature, or maybe inadequate breathing notification. Especially the problem is in the pediatric age group because they have larger surface area and they have immature temperature regulatory mechanisms, and hypothermia causes in this patient many problems. One of them is coagulation effect or dishydratation. Prevention: use warm fluids or warm irrigation fluids, body warmers, adequate breathing, ensure normothermia positively before reversal, because if patient is hypothermic and you are trying to reverse the patient directly, you can have difficulty and you unnecessarily label this as delayed methods. And it is essentially to monitor the temperature in these patients because invariably the temperature in the increase of is around 22. The solution one with the skin temperature is very low, and even in the sympathetic pressure, coming to the hyperthermia, increased metabolic rate, increased blood flow, ICP, and it can occur because of the high temperature, especially OTs in the government sector when the AC is not working during summer months. Sorry, I just correct. History of febrile illness in the immediate window or malignant hypothermia, of course, prevention that use cold or body temperature fluids or IV therapy as well as for the irrigation. Maintain low OT temperature so that the ambient temperature is low. And focus again on the temperature essential. As I said earlier, hypoglycemia, hypoglycemia, extremely important. Glucose is the only substrate for the brain for its nutrition, and it is mandatory for the brain cell for its survival. Then hypoglycemia can be a problem. Hyperglycemia can be. Hyperglycemia increases edema. Hypoglycemia increases ischemia, and both may lead to the increased ischemia. And this may be a neurological ischemia. So, contributing factors, as you know, that prolonged aging in this period, patients who cannot take their food because of the altered sensory, they are only on IV fluids, or overfasting in the pediatric patient, diabetic patient, elderly patient, elderly patient. So, contributing factor for hypoglycemia is diabetic patients who are not controlled well, patients on steroid therapy, patients in a lot of stress, injury. Confirm the pre-op status of diabetes in one month. Always find out the fasting and BP levels and HbA1c. Avoid glucose containing IV fluids. Close monitoring of blood glucose control. Prevent all stress responses during the pregnancy. So, coming to the next topic of initial embolism, deep incidence. There's a misnomer that venous air embolism only occurs in certain conditions, but that's not so. It occurs in many other conditions also. 8.3% in lactate, 10% in position, maximum incidence about 40% in sitting position. What is important is that the factors who are responsible for the air to get into the venous breathing habit. It occurs if the pressure gradient between the right heart and the upper pole of the cm. The common sources for the air to enter is the pressure when there are open suboccipital venous flexes which are attached to the patient muscles, non-collapsible venous sinuses due to attachment, the fixed walls of the fluid veins, and open veins in the bony edges when you are looking at it. Now, the effect. There is a ventilation perfusion, abnormality, cardiovascular collapse, pulmonary hypertension, edema. Recognition is by sucking noise on the surgical side if too large amount of air is being sucked, or feeling radial change in Doppler sound, or falling the PCO. This being normal, many of the clinical setting PCO is monitored, so that's the first sign that we observe. They will rise in pulmonary artery pressure, falling fluid open body, CO2, hypertension, other pneumonia. Now, management, inform surgeon, stop nitrous oxide, oxygenate when aspirate from the central venous catheter, raise the cerebral pressure or compression. If the symptoms are severe, regular, management, again, treat cardiac arrhythmias, initiate CPR of the cardiac arrest. Sometimes the reports are there, they are doing the cardiac process with cardiac aspiration of the ventricle, that was used. There should be a right rapid volume expansion with tension of the situation. Prophylaxis is most important. Preoperatively, do the proper assessment, suspicion of cardiac problem, like get it checked with your cardiography. Avoid sitting position as far as possible. Avoid nitrous oxide. Ensure adequate circulating urine bed and free water. Prophylaxis again, use control movement. Increase the cerebral venous pressure. Active post-1 nutrition with some amount of fluid. Use anti-diabetes so that the venous is improved. Prophylaxis by the surgical team is done in the embolism occurs. Continuous purification of the surgical team. Central control of the venous bleeding. Application of the bone wax to the periphery of the disease, being of the uses. What are the monitoring tools? The less sensitive ones will know now. The old days that used to be disciplinary studies. This will give you some change in the PAT sounds. Pulse oximetry, this is calculated. The sensitive ones are Doppler, ultrasound, ETC, primary application. But very sensitive is N2 and nitrogen. And TE, of course, these days very sensitive facilities available, and that should be used very cautiously without causing any damage to the wound. Coming to the other direct complication which is associated with the sitting position, pneumothorax. Most common in posterior fossa, where the coming with the head of posture. Pressure in the collection may or may not be able to equalize with the atmospheric pressure. The end says that the N2 augments the volume of the trap there, and therefore it should be discontinued before the dura is closed. But if there is a tension pneumothorax, one of the causes of delay is other thing, and it happens after the posterior supratension. So checking for the signs and symptoms of tension in these two positions is very, very useful. Diagnosis of pneumothorax is usually done by lateral X-ray, CT scan, treatment that immediately goes to one hole on either side of the distant frontal bone, and with the maybe puncture, you can the incidence of pneumothorax is about 3%. Post-operatively, if you are detected, intraoperatively, cause confusion, very convulsions, neurological deficit, failure to regain consciousness. There may be sometimes life-threatening pain herniation. Avoidance of nitrous oxide is really not being helpful. It may not eliminate the risk of pneumothorax totally. Now, what is the mechanism? What are the causes? Decreasing the urine volume with mannitol, filtration of the soil, reduction in the intravascular volume with hemorrhage. The gravity helps the gravitational effect of the circulation is responsible for air to go up in plasma activities. Or intraoperative removal is continuously done. So there is a typically inverted pop bubble inhalation. The CSF pours out and the air bubbles being up in the plane. So that is when slow continuous gravitational release of CSF can result in accumulation of air in the subcutaneous space. Therefore, it is advisable, if it is not really mandatory to do a continuous drainage, primary drainage, it should be done only when it is needed. Aneurysm, subarachnoid hemorrhage, and SIDH or cerebral solid crystal syndrome common with aneurysm. Vasospasm with the subarachnoid hemorrhage is common with the aneurysm. Now this happens because of the breakdown product of hemoglobin from blood accumulated in the circular fluids. The triple H therapy that will cause hypervolemia, immunization, and hypertension will not go to details of further distinct. Subarachnoid hemorrhage may be associated with myocardial dysfunction, cerebral ischemia, bleeding, or rupture. During anesthetic technique, there has to be absolute avoidance of acute hypertension, provision for intraoperative weight relaxation, maintenance of high normal breathing ability, critical reduction of blood pressure. Preparedness to perform precise manipulation of the vehicle. Now, decreasing the in emergency situation with bolus of carpenter or Betacon, increase the oxygenation within the fluid channels, apply the similar therapeutic pressure to prevent bleeding. AVM, avoidance of acute hypertension and capability to manipulate this activity in the bleeding. Perfusion pressure breakthrough can occur in cerebral dysautoregulation. plus it could be hypertension, post-operative has to be addressed. The stereotactic surgeries, the problems are restriction of the airway access because of the brain, and if the patient loses the airway because of the oversedation, then tackling the airway usually becomes a great maneuver. And therefore, as I said, that even in this patient, the airway assessment and airway tools should be handy. While doing the stereotactic either in the CT or if you are doing it in an MRI, then MRI compatible equipment to secure the airway in the MRI suite. Now, if you are doing the electrophysiological recording with the stereotactic training, it may be done. The choice of sedation depends on what you use in your institution while placing the electrodes. Now, it is important to detect and manage the complications like seizure. These patients are awake and they may have episodes of seizure. They may have the intracranial hematoma because of the improper fixation of the brain, or if the sedation is employed. Therefore, monitoring of the airway frequency and monitoring the ventilation is extremely important. In case of urgency, the surgeon should be able to remove the brain. Diabetic insipidus is recognized in the disturbance after delivery about 20% of the cases, and it is due to the manipulation of the pituitary stalk. It may occur as a transient distinct disturbance and may get corrected by itself within 48 hours. But if it is not continued as polyuria, hypernatremia, and plasma osmolality, we may have to treat the DI actively with adequate fluid resuscitation, correction of electrolytes, regular monitoring of intake and output, and A.M.Deshpande to correct the DI. SIDS may be due to inoperative release of release from distributed fluid, but it is rare. Now, in SIS, the important to differentiate the SIDS from the cerebral salt wasting syndrome. SIDS is treated with the volume restriction. However, the cerebral salt wasting syndrome is treated with the fluids. Therefore, summarily, majority of the complications can be prevented by strictly adhering to the principles of anesthesia and following usual protocols. Some of the complications are inherent to the procedure, such as diabetes insipidus, cannot be totally eliminated, but should be promptly diagnosed. The incidence of complications like venous air embolism can be minimized by combined approach of anesthesia. Thank you. Thank you very much. That's the end of my talk. Hello?
Yes, ma'am. Thank you, ma'am. Yes.
I have not been able to touch upon many other things because they are not directly in the purview of the anesthesia fraternity. They are more related to the neurosurgery, and we may not see them intraoperatively or even in the ICU setup. They are more related to the neurosurgical reasons and the post-operative. Pardon?
Thank you so much, madam, for such an elaborate and practical session on avoidance of complications following neurosurgical procedure. Now, we, the Society of Anesthesiologists of Pune, would like to felicitate the Dr. Bharati Kondwilkar madam for the 6th Dr. A.M.Deshpande Oration Award 2021 for her exemplary achievement in the field of anesthesiology.
Thank you very much for those bouquets and for those trophies. I feel nice. Again, feel like we are in the academic arena after a long 4 days after my, and the talk was very exhaustive. I also feel exhausted at the end of it, and I'm sure that all those listeners must also have been exhausted listening to my talk. So please pardon me. There were a lot of repetitions are there, but they were unavoidable. Thanks once again to this thing to Staff Society of Anesthesia PUNE and also PUNE, and especially who has been happy to following this process long time. We had twice to debate, but I think today was a right day, Teachers' Day, and it is to honor Dr. Deshpande Oration, scholar of Histology and Literature in the anesthesia faculty. Thanks once again.
Thank you, madam. Now, the questions for this session and previous session, we will take after panel discussion. We will proceed now for the lunch break, and we will assemble for the panel discussion on traumatic brain injury at 2 p.m. sharp.
Okay, thank you very much. Should I just leave the session?
Yes, ma'am. Yes, ma'am.
And this thing come back again, no?
Yeah, come back at sharp 2 o'clock.
आता आपल्याला फक्त ते पडद्याचं ते ऍड करायचं
मेसेज पाठव. ते असं का आलं? ते काय? कळलं नाही मला. पण दिसत नाहीये नाही का? मिनिट आपला.
Hello.
हा, हॅलो मालती.
Hello, madam.
Yeah.
How are you? काय म्हणताय?
Yeah, I'm good. Yeah, fine.
It was wonderful. Your lecture was really beautiful. तुमचे आणि कोंडविलकर मॅडमचे.
No, I'm Dr. Pradnya speaking to you.
Oh, is that so? I thought Karnik madam was talking. Acha.
Yeah.
She unmuted. Okay, okay. Right.
Both of them are
Thank
wonderful.
you.
Yeah,
Thank you anyway, but
yeah.
you are doing a lot of pain, I believe.
No, madam. No, no, no. I do a lot of neuro and I was doing a lot of regional anesthesia as well before.
Achha, regional.
Yeah. My husband's a neurosurgeon, so I automatically get to do a lot of neuro work.
Yeah, I was told by our neurosurgeons that. Yeah.
So both of us are from KEM Bombay.
Hmm. And now you are in Pune.
Now, yeah, almost now, I think 25 years I'm in Pune.
Okay. I'm hoping to relocate to Pune after a few years. So probably I will be a member of SAT.
Okay, ma'am.
Of course, of course, of course. You'll have the benefit of your wonderful academics.
At least I would like to attend your academics because they are very regular and good ones.
Oh,
I will become a member maybe 2 years later.
correct, correct. Acha, you have retired or not yet retired?
I will be retiring later after 2 years.
Oh, acha.
So planning to settle in Pune.
Okay. You already have a flat here?
Yeah.
Okay. Good, good.
Yes.
Just wait for a couple of minutes.
Yeah.
So that ma'am comes in. For all the delegates, the feedback form has come on the chat box, so you can fill it after this session is over. The feedback form is essential for getting the MMC points, so we need to get it. So it should be filled. Just a couple of minutes before Madam joins in, I have just called her, so said she will be there in a couple of minutes. A very good afternoon to you all. We are today going to deal with a very important topic, which we actually come across in our day-to-day practice, either as an intensivist or an anesthesiologist both. Now, why is this particular topic so important? Traumatic brain injury is a major health problem, and incidence in our country is like 1.5 to 2 millions per year. The mortality rate is also high, and how to kind of decrease this mortality when the patient is shifted to the ICU pre-operatively itself, and how to kind of decrease the problems intraoperatively also is a major concern in decreasing the death rate in these patients. The leading causes of traumatic brain injury include road traffic accidents, which we hardly can avoid actually. It could be falls, especially in children, or assaults, which are very many, which we already have. We always read it in the newspapers that we have a lot of assaults and homicides which are happening, and due to which the rate of traumatic brain injury is high. So this panel discussion on traumatic brain injury includes the panelists Dr. Malati Panchawagh, Dr. Hemangi Karnik, and Dr. Kondwilkar, ma'am. Now, we have already heard about from the stalwarts in neuroanesthesia, Dr. Karnik and Dr. Kondwilkar, and Dr. Malati is the younger of the lot. Malati is an extremely pleasant personality, and what she appears to me as an extremely intelligent student she must have been. And the way she behaves in the OT with the patient, I have seen it personally. The patient first remembers the anesthetist and then the surgeon. She is presently a senior consultant anesthesiologist in the perioperative physician at the Sahyadri Super Speciality Hospital, and she also works in the M.J. Joshi Memorial Hospital. Earlier, she was working with the Dinanath Mangeshkar Hospital, where she was majorly doing a lot of orthopedic surgery. Her major achievements are that she has been invited at various state and national conferences and even international conferences to speak on neuroanesthesia and regional anesthesia, has multiple posters and papers to her credit. One of her very good article was awareness of blood transfusion among nurses in the tertiary care setup. And it was actually published in one of the very prestigious journal, a very highly indexed journal. So now the other speaker, Dr. Hemangi Karnik, has already been introduced. She has so many feathers in her cap. And Dr. Bharati Kondwilkar, she's a teacher of teachers. Actually, all of us know her as juniors, and she really does not need any introduction. We have already heard her massive experience on neuroanesthesia. So now let us move on to the panel discussion. And the first question will go to Malati Panchawagh, the second to Madam Karnik, and the third one to Kondwilkar ma'am. So now, as we already said, that our incidence of traumatic brain injury is so high, and it's not only the brain which is affected, but it is also the other systems are involved. So what are the effects of traumatic brain injury on the brain and the CNS itself, Malati?
Yeah, hi, and thank you, Pragnya. I'm really honored to share this panel with Karnik Madam and Kondwilkar Madam. Both of them being doyens and great academicians, I will try and bring a little practical aspect to management of traumatic brain injury. And so I'll try and make this more interesting for people who are practitioners rather than academicians. So the effect of traumatic brain injury itself is a very great spectrum. It includes from mild concussion at the mild end of the spectrum to a very severe neuronal injury leading to possibly death. What it really means is that there is an external physical force which has led to either axonal injury or has led to a contusion or has led to a hematoma or any such problem, either in the supratentorial or in the infratentorial compartment, which has led to disruption of the neuronal system. this itself actually leads to either hematoma, a vasogenic problem which will occur there, or there is ischemia and necrosis of the neurons. So traumatic brain injuries can basically be divided as the primary injury which is the one which causes the brain to dysfunction, and secondary effects of the primary injury. So it's like an umbra and a penumbra that are occurring. So both of these can lead to very deleterious consequences depending on the extent to which and the speed and the type of injury which has occurred.
As a secondary effect on the brain, the other organ systems are also affected. Karnik ma'am, could you just throw a light on this? Ma'am, you need to unmute.
The brain being brain, it affects all the body organ systems because it basically controls every other system. Some of the system effects are well known to all of us, like when the patient is having severe head injury, the hypertension or tachycardia as well as bradycardia is very commonplace and we all know about it. But besides that, there are several cardiovascular changes as well, like there will be several arrhythmias which are possible in the brain injury patients. In fact, while looking after the trauma ward, I have seen all the types of arrhythmias in the severe traumatic brain injury. It can also cause cardiomyopathy. In LV dysfunction is also known with severe head injury patients. Respiratory system also, there will be some sort of neurogenic pulmonary edema, pneumonitis, respiratory irregularities. All those things are also known and we are dealing with it day in and day out. But besides that, there are other systems which are also affected and quite often they are either missed or underdiagnosed. Are the systems which are endocrine systems. There are in the acute phase, there can be adrenal hypofunction, thyroid hypofunction. There can be ADH abnormalities, and you can see that diabetes insipidus or cerebral salt wasting syndrome or SIADH, any of these are possible. Even later phase also there can be GH and other abnormal endocrine function can be seen. One important thing is the coagulation system also gets affected, and it's very common that we have seen the large contusion patient developing coagulation defects because the tissue factor or thromboplastin is released into the circulation, leading to the coagulation cascade, and then relatively or secondary thrombocytopenia and the clotting factor defects are also commonly seen. Besides that, there are GI changes and hypermetabolic state requiring more energy requirement. Gastric ulcers are common, hyper as well as hyponatremia, those things are also common, and almost every system, even the renal functions are also getting affected, and secondary renal dysfunction is also seen. So practically when patient comes with a head injury, we need to identify and deal with every other organ system. Thank you.
It becomes a multi-systemic disease and you cannot just look at the brain. Now, this is one question which is so important for an anesthesiologist, because anesthesiologists, even if they are not manning the intensive care unit, will be called in this situation. And this situation is a little different from other difficult airway situations, which Madam has already told in her lecture. So what are the guidelines for intubation in traumatic brain injury? At what point do you intubate? How to intubate, and what are the challenges therein? Ma'am, please unmute. Yes, ma'am.
Two things I would like to highlight in this aspect of there are so many myths about intubation in these patients. The most important thing, as soon as you receive the patient, very nice. And accident has fallen down and had this thing sustained with traumatic brain injury or any other cause. Another at the time of injury, some drug or
There's a little bit of a problem in your audio. Is there another mobile phone close by which is on or something, ma'am? You can keep it at a distance.
Okay. Is that okay now?
Yes, yes.
Mobile is right. So the decision to intubate to be visualized rather than
Recording in progress.
times. There to decision, but that will have to be deviate sometimes.
Ma'am, again, you're not very audible. When you said, am I audible? That was the best.
Hello?
Yes, ma'am. Yes.
Can you hear me now?
Yes, ma'am. Yes.
Okay. The guidelines describe that anybody who has got a poor distress score should be intubated. But then that is a very big term. Okay? There are in-between cases also. They may not be still maintaining the airway, or they may have difficulty in maintaining the airway because they are intoxicated. They are aspirated. Okay? Or they have this thing, cervical spine injury, by which they will not be able to maintain the thing, their position, so that the airway remains vacant. So it is not only the GCS scale of 8, but all these patients who have these problems, and if you are monitoring states that okay, they are not maintaining saturation. If you have the listing, it is there and it is connected to your mass vein circulation, what is the ATC2, then you know maintaining the listing, it is maintaining the carbon dioxide, is not maintaining. So in all the situation, the intubation has to be considered. How to intubate? Again, most important in severe traumatic injury and or maybe in a moderate and there could be some cervical spine injury. So that you have to at least the clinical judgment that the patient has got some cervical, or you have to assume that he has, and therefore I have to take due precaution that you won't do a lot of movement in this patient and you intubate the patient. Not everybody will not have the all gadgets available because you have to avoid hypoxia and hypercarbia. These two distinct factors which are very, very distinct, detrimental on the CB and ICF and all that dynamics. So how to integrate that, always consider. This I have instructed everybody that whether cervical spine injury or no injury, intubate this patient if you require with the manual line stabilization. Okay. Consider this patient, they have the full stomach and they need to take precaution. And of course, those who are below 8 don't require anything. And if they already cervical spine injury, the prevention of hypoxia is much more important than doing some manual displacement of this thing is important. So these are the considerations. Okay? The guidelines will keep changing day and then, but these are the key factors that have usually has to consider. They are most important factors to consider the intubation of injury or
yeah, so the take-home message is you need to oxygenate the patient, come what may. Don't worry of the slight rise in ICT which may occur during the process. Worry about the cervical spine, but worry about the oxygen as well. So now back to Malati. As we all know, we are worried about the ICP in all these patients, whether they are in the ICU or whether they are in the OT. So what are the techniques to decrease the ICP in the ICU particularly?
So,
Yeah.
so it's similar to what we have been taught in the operation theater. Of course, there are certain things which are different. When you first get the patient in the intensive care unit, probably the patient is already intubated and probably has a cervical collar. So the first thing that one has to check is that the cervical collar is placed well and that there is no compression caused by the cervical collar, because you need to see that the jugular venous drainage is. And somehow there's an echo. One sec. Can you hear me?
Yeah, I can hear you well.
There is some problem here. Can you hear me now?
Yeah, I can. Yeah.
Right. So the thing is, checking the cervical collar, giving a propped up position, these are very important to ensure that there is good venous drainage. Like Madam Kondwilkar explained, 80% of the intracranial pressure or the volume is contributed by the brain and nearly 8 to 12% by the blood. So the blood, almost 8% is from the venous drainage. So ensuring adequate venous drainage is very important. Maintaining blood pressure is equally important because that gives the arterial flow, and preventing hypertension as well as hypotension, both are important to maintain. Like we know, ICP is dependent on the arterial flow, the venous drainage, and the brain volume that is there. So any increase in any of these components is going to cause increased ICP. So maintaining good oxygenation, preventing hypercarbia, preventing hypocarbia, maintaining good blood volume, euvolemic, not hyperhydrating the patient. These are also very important to keep the ICP in check. Similarly, and ensuring that the patient has good analgesia, because an agitated patient who is having a lot of pain has worse hemodynamics, as well as it tends to increase the intracranial pressure. So maintaining good analgesia and giving seizure prophylaxis. Seizing patient is also likely to have higher intracranial pressure. Other than this, of course, using osmotic diuretics like mannitol. So there are multiple tiers. There are different ways or different tiers in which we use diuretics. First of all, we try to use mannitol as indicated. And if we think that mannitol is working well, then that alone should be sufficient. We use varying doses depending on the situation and the hemodynamics of the patient. 0.25 gram to nearly up to 2 gram per kilo. There is a very wide variation, and depending on the blood volume status, one has to be careful. The second would be hypertonic saline, and generally Lasix is avoided unless there is some other indication to use a third diuretic. So like we said, maintaining intracranial pressure or reducing intracranial pressure cannot be seen all on its own. It has to be seen with respect to the rest of the hemodynamics and how the rest of the organ systems are also functioning.
Yeah, so it is again a multifactorial thing, and maintaining ICP to a particular, we cannot say whether it should be below a particular level or above a particular level. It has to be as per case, and it has to be at the optimum, right? Now, when and why does ICP rise in traumatic brain injury, and why should a normal ICP be maintained? Like I say, I cannot decrease the ICP, let it be. So is it right? Karnik ma'am.
Actually, Kondwilkar madam has expertly explained this, that why and how the ICP increases. Cranium is a closed cavity and containing the brain, blood, and the CSF. And because it has the fixed volume, there cannot be any extra volume coming, no space for the extra volume to come in the say. So whenever there is some increase in volume of any of this, something has to go out. Usually in traumatic brain injury, we are talking about the hematoma. That's an extra new place coming, a new segment coming in. So initially there is some compensation because of CSF from the intracranial portion going out into the spinal space, and also to some extent venous blood comes out of the cranial cavity. So initially, as the hematoma forms, there is no change in ICP. The patient tolerates the increase in volume. When the further hematoma expands, there is no more compensation possible, and because of that, slowly the ICP keeps increasing. And even if there is a slight increase in the volume, there will be sudden increase in ICP. So somewhat at one particular critical point, if the volume increases beyond that, there will be sudden rise in ICP. And that is what we are trying to prevent by using these different techniques to reducing. As far as whether we should maintain a normal ICP or no, I wouldn't call it as a normal ICP, slightly above that level, but definitely below the critical level, we try to maintain it. If we don't maintain it below that particular level, sudden rise in ICP will be there. Then there will be a lot of resistance to the blood supply going into the brain. So effectively, it will cause initially focal ischemia and then the global ischemia. So the cerebral perfusion pressure will get affected. Brain will not get adequate blood, and there will be secondary changes or secondary injury also contained. Not only that, if the hematoma or the rise in ICP is restricted to one particular compartment, say supratentorial one side, then it can have herniation syndromes. Wherever the rise ICP is there, it can cause initially midline shift or herniation across the falx or the uncle herniation or anything. It tries to go, the brain will try to go into the other compartment, and that herniation can be catastrophic. If there is a global rise in ICP, then there can be coning. The whole medulla can come down and there can be immediate catastrophe. So that is why, to prevent herniation and to maintain the normal blood supply, or at least critical amount of blood supply, the ICP needs to be maintained. If not normal, slightly at a higher level. You can have your own cutoffs like 20 or 25 or whatever. Thank you.
Thank you, ma'am. Kondwilkar ma'am, does a bulging brain intraoperatively always mean that there is a rise in ICP? Or there could be something else? Like we often we try to decrease the ICP, but the bulging brain still persists. So what could be the reason? Ma'am, unmute. Yes, ma'am.
As far as I know, that there is a lot of confusion amongst many people. Raised ICP means brain edema, but that is not so. Brain ICP, raised ICP may be a very transient process. Even if you say you are being succinate, there is a transient rise in the distinct intracranial pressure. That subsides on its own within some time. Okay, so it is not necessarily that raised ICP means bulging brain. Brain may be there, may not be bulging. The bulging brain edema implies that there is a shift of fluid from one compartment to the other compartment. Now, once this cranial cavity is open and the edema is open, as I described earlier, there is no meaning for ICP. The ICP is equal to atmospheric pressure. So you cannot talk in terms of raised ICP when the brain is open. It is only this thing can be described or can be described or treated when the device closed. Okay. So bulging brain intraoperative means the brain was already edematous and now it is popping out. Okay. So that is the situation. Now that popping out brain edema is there, open whole region, it is causing compression of the other compartment, one compartment, and now since now the space is available, it is taken out of the cranial cavity. So that's what clinically we see. So we always say bulging. But what is the ICP? The ICP is not there. Okay? Now, there could be a situation where there is no brain edema. The tumor is growing slowly and there is no brain edema, or there could be very minimal edema and intraoperative and the ICP is also not very critically raised, and then you open a video. Okay? And suddenly you find the brain starts bulging. That means there is something which has happened acutely, acute catastrophe. And that acute catastrophe, remember, underlying whatever it is, like the surgeon has done something. It is from the surgical side that is happening. That is what it is. It is some visual vessel means brain has been populated. For brain, remember that more than the arterial system, the venous is extremely important. Extremely important.
Yes.
The investment is there. There are a lot of things can happen which are the function of the brain unit. So any of these things which are brain which is being formulated, you will see that the brain starts bulging. Or if he has been handling unnecessary areas which is not supposed to be seen, that a lot of handling of the brain tissue also. So these two situations are totally different. Now, ICP may raise, let me explain that. ICP may be increased intraoperative, sorry, preoperative, because the growing brain tumor has not grown to a critical level, and the patient may be just showing some clinical signs and symptoms of this anxiety, like sleepiness, and then some things. But you will definitely see that brain edema on radiological. This is called radiological edema. The patient may not be very clearly single. So it's better to see on an X-ray or CT whether the patient has got a radiological imaging edema. So ICP raising an edema is different. And the pros and cons of that sometimes the acute edema, acute brain edema that develops because of some mishandling or profuse bleeding or formation of the brain during intraoperative. They are very difficult situations to manage. Even if you do manage in this situation, what does manage? Management does not have it acts on the normal tissue. Okay, and it tries to shrink that area. Okay, because of the osmotic cooling. It doesn't really work on the singular tissue or maybe not tissue. That's on the normal tissue. That way it shrinks that area. So try and making some space for that developing area. That is a distinct principle of doing mandatory in these cases. Demandatory. But the actual distinct treatment for these cases, giving the distinct mandatory, it is very temporary. But the actual distinct is that debulk that hematoma or tumor as soon as possible with minimal handling of the normal tissue. Thereby, you can really help reducing the bleeding.
Okay.
Contrary situation is there in the head injury, because the head injury, the development of hematoma is very sudden. Profuse bleeding, intracranial bleeding, maybe subarachnoid bleeding. Okay, so there is the same development of pathology on a different level, acute setting. Whereas in a tumor situation, this setting is very slow growing, or it may go worse once the capacity of the usual box is lost. Phenomenal compensation happens very fast, and therefore your ICP starts rising.
Yes. So basically, it even depends on the etiology of the particular disease regarding how to control the brain bulge, besides the rise in the ICP per se.
So that is why it is important for the anesthetist to have a look at the X-ray or scan and see whether the patient has any signs of missing brain edema, which is radiologically evident, and you have to take a due precaution in all the maneuvers, and whatnot, which will elicit a severe response and will increase further rise in the ICP and will initiate the brain edema if it is found there.
Okay, ma'am. Thank you, ma'am. Now coming to Malati, what is the importance of cerebral perfusion pressure, and how do we achieve a target CPP? We have various concepts about how much the MAP should be. We have a concept known as the Lanz cursor, which says that maybe you underhydrate the patient and keep a lower ICP. The other Rosner's concept says that you keep a patient at a higher mean arterial pressure, so kind of a permissive hypertension. So what is your understanding on this?
Yes, so basically, the thing is, all of us tend to talk so much about ICP should be less than 10, 20 to 25, or the CPP has to be 60, 65, 70. Actually, practically, when you start anesthetizing such patients or managing such patients, and very, very few of us and very few institutes actually have monitors which measure the ICP. Very few of us have intraventricular catheters. All that we are left to is monitoring very simple things which give an indirect reflection of what the situation is likely to be within the brain. And that is what we've got to go by. So coming back to your question, is cerebral perfusion pressure is mean arterial pressure minus ICP, right? So keeping the MAP high and keeping the ICP low is what is going to keep your CPP good. That means cerebral perfusion going to be good. So does that mean that having a very high MAP and having a very low ICP is going to be good for the brain? No, not necessarily. Having overperfusion can also be deleterious. So maintaining a good balance. That's why there is no single answer to this question. It again has to be seen as a whole, because the patient already has, like I said, there is a primary injury, there are secondary injuries, rest of the body. If there is polytrauma, the rest of the organs are also likely to be affected. So there is no single answer to this. But having said that, trying to maintain a MAP of at least 80 to 90 and an ICP which is reasonably okay is ideal for the brain. But again, based on what you think is normal and what you think is a euvolemic patient or having adequate blood pressure, adequately ventilated patient, if you feel that his neurology is deteriorating, you have to rely on other factors which are giving you indirect indicators of whether the perfusion is good or not. So you got to up titrate or down titrate whatever therapy you're instituting to see whether this is actually working for the patient. Because very few of us in big institutes, we have access to intraventricular catheters or maybe other kinds. I know of only 2 places in entire India which have triple bolts and such devices. Most of us work in places where you are left to fend with regular monitors, and these are indirect indicators, and the patient's clinical situation itself should tell you whether the perfusion is adequate or not. So theoretically, 60, maintaining a CPP of 60 is supposed to be enough. There is no need to go overboard and keeping MAP very high. But again, in certain situations, so we are now talking about traumatic brain injury, but again, if there is the blood-brain barrier is reached, if there is hematoma or if there is hemorrhage, you cannot keep the MAP high because the hematoma is going to increase, and the hematoma increasing is again further going to, so it can be bad for the patient. So there is no single answer to this. So you have to decide this based on the situation that is there.
Now coming to Karnik ma'am, there is a controversy about the role of steroids in traumatic brain injury as well as an SOL. What is your take on this, ma'am, and your experience as a neuroanesthetist?
To answer this question in one word, there is no role of steroids, means no. There is no role of steroids in traumatic brain injury. In fact, it has been associated, the evidence proves that the use of steroids in traumatic brain injury has been associated with higher rate of mortality. So the Brain Trauma Foundation guidelines, which have come several years ago, specifically say that use of steroid in traumatic brain injury is contraindicated. In fact, this is the only guideline coming from the traumatic brain injury, which is a level 1 guideline. And steroids are not recommended for TBI. But you did mention about the tumor surgeries, I mean tumors and all. And in those, definitely we are using steroids and the use of DEXA pre-operatively as well as during the surgery and all has a role in significantly reducing the edema, and that is why it is useful. Even some people are using DEXA even in traumatic brain injury, but it is absolutely not indicated. Thanks.
So traumatic brain injury, steroid is a no-no. Intraoperatively for an SOL, yes.
Yes.
Now coming to Bharati ma'am, when should mannitol be given in a case of TBI, either in the ICU or the operation theatre, and what are the pros and cons? Like we give mannitol, but we don't know when to start it, when we should stop it, how much we should give, should we overdo on our doses, because the surgeon is saying that the brain is bulging. So just a little, I mean, if you could elaborate on this concept. Ma'am, you need to unmute and then mute again after you're done.
Mannitol very favorite drug for anesthetics and surgeons. But if you see the Perioperative guidelines, recent guidelines, it has very clearly mentioned that mannitol should not be given until you have a fair idea, a good idea of ICP. That's a recent description of the guideline. Now, of course, in Western countries, they have the ICP catheters and monitors for when we start monitoring right at the beginning. But here, we do not have that facility even sometimes in ICU. Okay? So now to convert that scenario into clinical situation, okay, how do I judge whether the patient has got this ICP or not? It's my clinical sense. And my radiological reading that the patient has what is for whether the mannitol is going to help him or is not going to help him. So, having said that, if I am definitely sure that the ICP is definitely raised, on the critical levels of raised ICP and alignment is still ICP described by several people. Some say it is about 20, some say it is about 25. Now, we always take the cutoff line 20. Okay, the normal ICP is 10 or below 10. So, if I see that, okay, ICC, even on the radiological imaging, we see that this ICP is there, and we can't measure it, I will translate that into a term that it's a raised ICP. And when I have to discuss that my patient is going to have the ill effects of that raised ICP. Initiating mannitol therapy is reasonable. Now, mannitol therapy has to be repeated after 6 to 8 hours. Not repeated because it has not acted or it has not some effect on that, that does not mean we will find your mind. Though she has said that recommended is 25 to 1.5 grams per kg, but patient become over to 20 minutes. You see the effect of mannitol. So we can say half an hour's time. And that does not mean we will half an hour's time. But I will keep on with it. We have to get the exercise time for the mannitol to resolve its action. If it's not helping this mannitol action, that means something else you have to do. Or we just need like ICP patients with a head injury. Therefore, mannitol has to be mannitol repeatedly, it's a misnomer. Okay, sometimes it is not even required, or sometimes you will get given the mannitol during the transit when the patient comes to your hospital and immediately taking within 3 hours. Does it mean that you give the mannitol because now is in hospital? No. If you have a definite history that you have some pre-hospital treatment, the patient has been given mannitol, okay, he has not improved on this is present status, you need not repeat the mannitol. As soon as possible, try and see that you surgically remove the trauma and you surgically remove whatever is inside there. Or your request fraction is compulsory, you remove the request fraction. So the other missing line of treatment required to be taken with the mannitol is within a shorter period of time. That is what we see as a risk. The pros and cons of this thing repeated mannitol therapy is ineffective. It has to be given at regular intervals not in a very high dose, not chronically, if it is not helping. Nowadays, they say that instead of mannitol, hyperhospital are using like 0.3% of distance to sorry, saline. Would be better than mannitol therapy. So some institutions are using hypertonic saline to recommend it. So these are the listing. This is the taking message regarding mannitol therapies. And sometimes putting what of this thing harm to the patient rather than the patient. Possibly we put it analysis. And so many other things that I think I described in my lecture. Be careful while doing mannitol. It depends on where do you meet the patient first time. Whether the patient is brought to the ICU to stabilize and then will be taken to the.
Ma'am, may I interrupt? Madam, there is a lot of background sound, which is probably some echo coming from your side, and we are not able to hear you well because of that.
Now you can hear?
Yeah, we can hear you, but that echo keeps coming in, and so I mean, you're giving us so many inputs, and we are not able to hear it.
Madam, if you are using earphone,
Huh?
if you are using earphone, just remove that earphone.
Shall I? Okay.
Yeah.
Now? Hello? Can you hear me now?
We can hear you, ma'am, but intermittently that echo keeps coming in. You don't have any other device which is on, right? On the Anesthesia TV or on the Zoom?
I'm logging to the Zoom only. What do you want?
No, only on one device, right? Now the echo has gone. You can continue like this, ma'am. Yeah.
Nobody is making any noise at home.
No, nobody is making a noise at home, ma'am. It's that echo which is coming. No, not a noise outside.
A little closer to the distance.
Yes, ma'am. Ma'am, you may continue. Yeah.
Okay. So I think if you are not heard, I will once again repeat that mannitol has to be given assessing the condition of ICP. That is the recent guideline given by the United Foundation. And they said that you measure the ICP and then give mannitol. If it is too high, the critical level, mannitol may not be visible. There is no place for this thing, the brain to swing. It is like the whole brain is matters. Okay. Second thing is that if the anadol is given in a pre-hospital care before it's come to you, then you need not report it immediately because the action of the mannitol is lasts for 6 hours. So ideally, it should be given in the 6 hours period, after the 6 hours period. Okay. Unnecessarily increasing the dose of mannitol from 0.25 to 50 or 2, because we can give 2 grams of this thing up to 2 grams, 2 grams. That is not a good logic. You can start with a basic dose. Instead of 0.25, you can do 0.5, but not initially only I'll do 2 grams. That's not very sensitive and logical. Another thing is that where you meet the patient first time, whether the patient is brought to the ICU to stabilize him because he may have some other issues like blood loss and some fractures are there, they may have to be immobilized and wait for the surgery, or you meet the patient directly. Because sometimes same things may be working in the ICU as well as working in the OT. So depending on that, how the patient is received, whether in the ICU, and then not within the 6 hours time, it should be repeated, not in very high dose. If it is not effective, then not even repeated, having own hazards causing little imbalance and autoimmune and maybe other basic problems, which I described in the lecture. Some people are preferring to give hypertonic saline and they found good results. These are my 4 or 5 lines that I described.
Thank you, ma'am. So basically, you start with a smaller dose, give it at proper intervals and not within 6 hours, and try using hypertonic saline and don't overdo on mannitol. Now, coming to the next question to Malati, it's going to be a little bit of overlap, but what is the fluid management in traumatic brain injury and what are the principles of using various fluids? Malati, you need to unmute.
Yeah, so first of all, so let me just elaborate a little bit on what Kondwilkar madam said, is that mannitol is a double-edged sword. So using it in the right dose is most important. In cases of mild TBI, maybe just a concussion, very small amount of amnesia, and patient is otherwise conscious when he's brought to you, there is no role of mannitol. So you have to decide at the end if the CT scan is normal and is just showing you a primary concussion. There is no need. You can withhold and wait and watch and see what happens. Now, apart from this, if there is, apart from mannitol, the other IV fluids that we are thinking of are crystalloids. So crystalloids, again, we all know that they're hypotonic, hypertonic, isotonic. And to maintain good intracranial pressure and to maintain good osmolality, it is essential to use isotonic fluids rather than hypotonic. Ringer used to be very popular, but before, maybe 20, 25 years ago, because it was a balanced electrolyte solution. But using Ringer is a slightly hypotonic and is likely to increase brain edema, and therefore it is not a fluid of choice. The fluid of choice is normal saline, and we can add electrolytes as necessary based on the electrolyte disturbances or the basic electrolyte panel that we have got of the patient. Using starches, again, if there is a disruption in the blood-brain barrier, using starches can be dangerous for the patient because they tend to go out and they tend to pull fluid and they tend to increase the brain swelling and brain edema. So starches is not something that is a go-to fluid initially. Then the fourth is using blood and blood products. Using blood is essential if the hemoglobin has dropped, if patient has polytrauma. And albumin is not something that we use regularly to maintain the oncotic pressure. But in chronic cases, if the parenteral nutrition is not good, for some reason the enteral nutrition is not working well and the patient is having low oncotic pressures, a small amount of albumin can be considered, but not in the acute setting.
Yes, and thank you, Malati. Now moving on to Karnik madam. Another controversial part. Now, many of us think that dextrose should not be used at all. And because it will cause a rise in the blood sugar, may not be hyperglycemia, just a normal rise in blood sugar, and it could be detrimental. Ma'am, what is your take on this? And how obviously we are not okay with hypoglycemia as well. So what should be our blood sugar control and whether dextrose should be given or not?
I'm glad you have asked me this because I like this question. First, as you said, we are absolutely not okay with hypoglycemia. Brain cannot store glucose and brain is dependent on continuous supply of glucose coming from the circulation, and that is why hypoglycemia should never be allowed to happen. And continuous blood means adequate blood supply containing at least normal level of glucose is essential. So that has to be monitored and ensure that glucose is being delivered to the brain. One thing. As far as the dextrose containing fluids are concerned, dextrose containing fluid, meaning if we say 5% dextrose, then as Dr. Malati said, that it becomes a hypotonic. It increases edema, cerebral edema. So it is a big no. As far as the isotonic fluids with addition of dextrose is concerned, so that the patient continues to get adequate glucose, there is no specific contraindication per se. To deliver glucose to the brain, dextrose can be added when needed, but blood sugar should be properly monitored. Why do we have this hesitation that the dextrose should not be given to the brain? If there is cerebral, if there is hypoxia, and if there is lot of circulating dextrose available, then what will happen? If there is no hypoxia, glucose is available, glucose will be metabolized properly into the mitochondria and Krebs cycle, through the Krebs cycle and all, and enough energy will be produced. However, if the glucose is available, lot of glucose is available and oxygen is not available, then only pyruvate will be formed. The proper complete metabolism will not take place because there is no oxygen. And then there will be pyruvate will be converted into lactate and there will be excess of lactate. Now this excess of lactate is going to be harmful to the brain cells. And that is why if there is no oxygen but more of glucose, then it will be more harmful to the brain. And that is why that condition should be avoided. So if there is any focal hypoxia or global hypoxia, then having a higher blood sugar is bad for the brain. As far as the general glucose is concerned, if the oxygen supply and oxygen delivery is adequate, giving a normal dextrose is an essential item rather than a necessity, rather than a luxury or a bad thing. I have seen that when people are being told that in traumatic brain injury, glucose containing fluid should not be given, but blood sugar should be monitored, what happens? That should not be given happens very easily and is properly followed, but the monitoring, blood sugar monitoring at a frequent interval is not happening. And I have seen pregnant patients, 9-month full-term pregnant patients, not being given any glucose for 4 days, GCS going down. And then suddenly when we find it, then we find the patient in hypoglycemia, then have to given, and the bolus has been given and the patient becomes all right again and all. Such things should be avoided. Always ensure that there is adequate glucose level maintained. If required, give dextrose containing fluid. If we are not giving it, ensure that there is no hypoglycemia occurring. Usually we try and maintain around 110 to 140 milligram percentage rather than having it too low or too high. Thank you.
Test is going down. You have to rule out hypoglycemia before thinking it's a deterioration of the traumatic brain injury event.
Yes.
Now coming back to Kondwilkar ma'am. Ma'am, please unmute. What electrolyte imbalance is seen in traumatic brain injury and what is the role of magnesium in TBI?
I'll just take a liberty in this discussion that there's again a misconception about this fluid. Glucose containing fluid and fluid for maintenance and glucose for caloric intake. There are two different things here. So many a times the students they ask me, why not do 5% dextrose? Okay, that 5% dextrose is going to be into the water and going to add to the. And then as she very rightly put it that we have to avoid hypoglycemia as well as hyperglycemia. And over a period of time, there could be a catabolic state where the patient will have a lot of metabolic changes. So you have to supplement that this thing. I used to use always this thing a slow this thing infusion of 10% glucose, depending on what is the blood glucose of that patient. Of course, blood glucose monitoring is very, very essential. It is one of the very important tool to guide you regarding the patient's progress under anesthesia and post-operative. So that was my comment on the addition to your history. Coming to the electrolyte imbalance in traumatic brain injury, as I have described the brain edema that occurs in traumatic brain injury is a vasovagal. Okay, and wherein there is a lot of this thing, there is a loss of sodium potassium pump. And the entry of this electrolyte is imbalance of sodium potassium distinct. So you might see hyponatremia or hyponatremia in these cases. That will come to know only when you use electrolytes. And that has to be this thing again checked time and again. If there is a hyponatremia, sometimes the patient cannot have any other element which is hyponatremia or hyponatremia is going down on his level of consciousness. As far as you ask me the role of magnesium, people have advocated magnesium, but it has no definite role. Magnesium has several distinct characteristics. The first one is that it has an anti-inflammatory or some analgesic property. Beyond that, it has not major role that has been described, and its use again is controversial. It has a definite role in your summer at night arrangement. There is a vasospasm. Hello?
Yes, ma'am. Yes. Ma'am, now you are better heard and the background noise is slightly better, less, what I mean. So hyponatremia is seen in these cases, and that is something which you want to bring back to normal. And we have said that you have already said that there is a role of hypertonic saline both to control the sodium levels as well as to control the colloid osmotic pressure. So, and regarding magnesium, yes, there is a role in terms of anti-inflammatory action which magnesium has. Now, going back to Malati.
Pragnya, can I just add a couple of things there with your leave?
Of course, ma'am, you can.
So like, Karnik madam spoke about dextrose and the presence of oxygen or the absence of oxygen. One of the newer methods of measuring what's happening at the brain level is to make a burr hole and introduce a microdialysis catheter, which is of course still in the experimental stage, but in very advanced, like 2-3 years ago when I was in Stanford, they were using this microdialysis catheter in their ICU. And what they did was they checked the ratio between lactate and pyruvate. So they send flushing fluid and pick up the extracellular fluid from the brain. It's sort of filtered. That's why it's called a microdialysis catheter. And they check the ratio between the lactate and pyruvate. So they try and analyze what is happening in the tissue fluid. We are talking about hypoxia at the PaO2 level. But what's happening to the oxygen in the brain? What is happening to the fluids, or what are the electrolyte components within the extracellular fluid in the brain? That is what is being analyzed, and that's where you can give targeted pharmacotherapy. So whether to give adequate glucose or not. So this is at that level that people are, of course, it's not possible for us in our scenario, but I just wanted to give a sort of backup to what she was trying to say about using the right amount of glucose. And yeah, sorry.
Ma'am?
No, it has also relation with the blood supply, and LP ratio is usually used to ensure that whether the blood supply, cerebral perfusion is adequate or no, and mainly that is put in the penumbra area, and also the focal ischemia can also be quantified, and then you can give according to that. But yes, that's a very good measure. Unfortunately, even after the 15 years, it has still remained in the experimental stage only and has not found a common place in the practice. Yeah.
It's very expensive. Even for them, it's very expensive. It's only when they have grants for specific conditions they are able to use it. Otherwise, they're also not able to use it regularly.
Yeah, when I had been to the same institute, they were not using earlier. Yeah.
Thank you, Karnik ma'am. Now moving on to Dr. Malati. What are the ventilatory strategies in head trauma? Now, there have been pros and cons of using PEEP as well. Like on one side, there may be improvement in oxygenation. In the other side, you may have an effect on the arterial blood pressure. So what is your take on this?
So I think the first thing is when to institute ventilation. It again depends on the GCS of the patient, the Glasgow Coma Scale. Anything less than 9 certainly needs to be ventilated. 9 to 12 is a gray zone where you have to decide based on other things whether ventilation is necessary or not. If the patient is not able to maintain airway, it's a very clear-cut case where ventilation needs to be instituted. What kind of ventilation needs to be instituted again depends on what the patient's trigger is and whether there is other kind of injury. Mostly we try and give complete mechanical ventilation without paralyzing the patient. Initially for intubation, maybe paralysis may be used, but later on, try not to use any paralyzing agent. And with adequate amount of sedation, you can maintain volume controlled ventilation. Again, here the strategy is to avoid volume trauma, try to reduce the amount of the tidal volume that is being used, try not to hyperventilate the patient. And an interesting thing is inspiratory pressure, peak inspiratory pressure, as well as the expiratory pressure. The peak inspiratory pressure again should not be high, because the peak inspiratory pressure also reflects on the intrathoracic pressure. The higher the intrathoracic pressure, the lower will be the venous drainage, and that will also increase the intracranial pressure. Similarly with the PEEP, increasing PEEP also increases the intrathoracic pressure and reduces the venous drainage. But again, having some amount of PEEP is essential. Now, what is some amount of PEEP? 5 to 6 centimeter water is a good amount of PEEP that needs to be used to prevent atelectasis, because we will be using oxygen at higher levels than normal, and prevention of atelectasis, patient lying down on on his back most of the time. This is very essential to keep the lungs open and to have alveolar recruitment. PEEP of 5 to 7 is not adequate to, or it's not high enough to prevent venous drainage. Again, higher amounts of PEEP are essential to get across enough oxygen or to remove carbon dioxide, which are also going to be detrimental. So PEEP alone cannot be, you cannot say don't use PEEP or use a lot of PEEP. This again has to be seen in the light of the other metabolic and hemodynamics that are happening with the patient. Second thing is, it also depends on the compliance of the lung. What we have seen is that if you have normal lungs, if you have otherwise ASA grade 1 patients who have not aspirated or who do not have chest injury, or for some reason have good airway pressures and good lung compliances, then higher amount of PEEP is going to be more dangerous for the patient. But if patient has an acute lung injury or has pleural effusion or polytrauma or a hemothorax or has neurogenic pulmonary edema, or for some other reason a pre-existing condition which leads to poorer lung compliance, higher amount of PEEP is good, because you are able to get across enough oxygen and to remove enough carbon dioxide, which is necessary to keep the ICP normal. Having said this, in any kind of lung condition, a PEEP of more than about, I think 14, 15 should not be continued for a prolonged period of time. Maybe short periods of time, this can be given. PEEP again is essential. Most of these patients have tracheostomy, or even in intubated patients, you might want to do suctioning. So before and after suctioning, that is when you need to institute for short periods of time. So like it has been the theme throughout from the morning, that everything has to be customized. There is no, not at all, or sometimes. So this again depends on the clinical situation. And that's why experience and knowledge is very important to know when to institute what maneuver.
Yes. Thank you, Malati. So optimization of PEEP as per the condition of the patient is important. There is no blanket rule on this. Now, regarding intraoperative hyperventilation, right throughout the residency, honestly speaking, Karnik ma'am, we have been hyperventilating the patient. And then as we grew, we got to know that there are several cons to it and not only the pros. So could you throw some light on this?
Just a moment. Before I go on to the intraoperative hyperventilation, I would like to add a few words about the PEEP. Dr. Malati very well told about the pulmonary compliance and the high compliance during the chest trauma and all. About the cerebral ICP also, if the intracranial compliance is also varying when there is a raised ICP. So in a normal patient, the PEEP, the way PEEP will affect the ICP and all, normal ICP, it will increase the normal ICP the same way the PEEP does not increase the higher ICP. Say a normal ICP may increase by 5 if PEEP is instituted. Similarly, if the patient's ICP is already 30, then it will not go to 35 or something like that, because the brain is less compliant. So the PEEP becomes less effective or less detrimental when the ICP is high. Having said that, another thing is we are getting a lot of polytrauma, as she mentioned, and quite often PEEP is essential to correct the hypoxia. If you provide PEEP, correct the hypoxia, then as she said, the ICP will actually improve. So PEEP is good, but the optimum PEEP should be used. And I just want to mention the ceiling to it. The ceiling level is up to 12 has been proven to be acceptable, provided no hemodynamic changes are taking place. So if you can maintain the blood pressure at the same level with PEEP, instituting PEEP up to 12 level, it has been proven in the literature that it can be safely given in the patients of head injury. Coming back to the intraoperative hyperventilation, yes, as Madam mentioned, the earlier guidelines by the Brain Trauma Foundation, the second guidelines, did mention that if the patient is rapidly deteriorating and we need to control the ICP fast till the patient is decompressed, then probably a transient hyperventilation was allowed. It was recommended so that quickly we can control the ICP and the surgeon can quickly decompress and all. However, this provision of a short-term hyperventilation also has been taken away in the third guidelines, the third edition of the Brain Trauma Foundation guidelines. Now, hypertension is not recommended. A normal ventilation or normocarbia is recommended because any hyperventilation is associated with the vasoconstriction and therefore reduced cerebral perfusion, cerebral blood flow and perfusion pressure. Now, where does this vasoconstriction take place? That is another interesting aspect. Okay, if we hypoventilate, there will be vasodilatation, there will be adequate blood supply and things on. But when we hyperventilate, which part of the brain gets the vasoconstriction, normal or abnormal? Quite often the abnormal brain might have lost the CO2 reactivity, but the normal brain is going to react to that hyperventilation by vasoconstriction, and it is the normal brain which certainly will get less blood supply if we hyperventilate. So it is the normal brain which is more at risk of ischemia when we are hyperventilating. So this is a big issue where hyperventilation can cause the secondary secondary brain injury and make the normal brain, the normal uninjured brain at risk. And I have seen the global infarcts also secondary to the prolonged hyperventilation. So that is a big problem and it should not be used. What will happen to the affected side? Probably if the CO2 vasoreactivity is normal, it will also have the same thing. Vasoconstriction will take place. That area also will get further low blood supply. If it is already affected and it is impaired, probably there won't be any effect on the effect of hyperventilation. So in that case, what will happen? That the normal affected brain, affected or abnormal brain will keep on getting the normal blood supply even when you are hyperventilating, and normal brain will get less blood supply. So if there is a midline shift, it will actually get accentuated. So we have to be extremely careful about this and avoid such thing. What we are trying to do is probably preventing coning and all, and what is actually happening is something different only, that midline shift gets accentuated and things like that. So probably it would not be a good idea to give even intraoperative hyperventilation, but having said that, still many people are using it for a transient time till the surgeon can decompress the brain, just in the hope that less than 30 minutes, the brain will tolerate that much hyperventilation and the coning can be prevented. However, this is removed from the guidelines and not to be used.
So use of transient hyperventilation and maintaining a lower CO2 in a situation where there is a lot of brain edema is an okay for a small period of time. Otherwise, we keep the EtCO2 levels at around 30 and to 35, and that should be enough for the particular patient, whether it is a head trauma in the ICU or in the operation theater.
Yeah, but the transient hyperventilation also is removed from the recommendations.
Yes. Now coming to ma'am, she's already told us actually about hypertonic saline in patients and when to use them. But what are the drawbacks of using hypertonic saline?
Okay, I would like to have some comment on previous to this thing. My experience I want to share on this topics. So please continue. The role of PEEP as Dr. Hemangi described, the level of chlorine. But there are distinct recent trends or some recent literature reviewed has said that normally when we are giving ventilation, there is, because of this thing, that there is an autoclave that is to the amount of 5 centimeters of water. So giving PEEP of 5 to 7 is of any no use. It is as good as not giving PEEP. But all you want to give PEEP, that is that 12 number has come. Okay, you give that 12 to 15. Now in a long term, that PEEP of that also is not good to help, because as Dr. Hemangi described, that if the ICP is really at the level of 30, that level of 12 centimeters is not going to do any more distance changes, that is going to remain there. And therefore, the strategies which were adopted by some workers is, rather than giving, this is in the ventilatory management, rather than giving PEEP to this patient to recruit the alveoli and improve the oxygenation, when you are giving the volume support, volume control ventilation, you add some pressure support to that, very minimal. That is much more better than adding PEEP. That was one thing I wanted to add. Coming to the hyperventilation, very categorically I mentioned in my lecture that hyperventilation, although these days recently, Trauma guideline has not made any comment on that, not recommended. But whenever it was recommended, it is used as a rescue mechanism, rescue treatment for a very short period. And because you have nothing else in the hand, so you do hyperventilation and try to squeeze a constriction and try to do it as much as possible. But even if somebody continues that for a longer period of time, over say 12 hours, the literature said fatigue of hyperventilation. Fatigue of hyperventilation. That means at the end of 7 to 8 hours, that phenomena of hyperventilation, the effect of hypertension wears off automatically. And she said it is more detrimental to the normal tissue than to the affected tissue. So hyperventilation therefore has been out of the evaluation. That is it. Because it is more dangerous to have a longer than this. Continuing doing the normal rate at risk, and therefore that strategy is completely out of this. Coming to my question of hypertonic saline, I think I said in the last question that this is one of the distinct hyperosmolar agent being used in many centers for treating your two advantages that the patient is on the low on the sodium side, it takes that. Along with that, also there is higher osmolarity of 350. After the osmolarity, in the longer run, if you do hypertonic saline, you can have the ideas of imbalances. If you give it too rapidly, hypertonic saline, higher concentration, then I will report of myelinosis. So this is my take on hypertonic saline. Anybody wants to add more than this?
Yeah. So we have used hypertonic saline. I will not say pretty often, but infrequently enough, especially in the operation theater situations, and occasionally before shifting the patient to the operation theater from the ICU. We give doses of 1 to 2 ml per kilo if the mannitol alone has not been sufficient, or during surgery if there is a lot of brain swelling. I haven't really seen in the last 20 years, I have not really seen pontine myelinolysis occurring because of use of hypertonic saline. Maybe others have, but that does not mean that we have to rush in and give high amount of doses. Of course, it has its negative effects and consequences of using hypertonic saline. But more important, when we are using hypertonic saline, like you mentioned, was to keep track of the metabolic acidosis. If you tend to use quite often repeated amounts of repeated doses of hypertonic saline, hyperchloremic acidosis is a very common occurrence, and it's difficult to treat and to get down frequently. In head injury patients, what we have seen is even slight amounts of hypernatremia of about 155 or so is not really that damaging. hyponatremia is certainly more damaging than hypernatremia, but again, we can err a little on the higher side of sodium as compared to going on the lower side of sodium. If the achievement of lowered ICP is what we are targeting, this has to be seen in the context of the patient and in what situation we are using this.
Thank you, Malati. So the take home is that hyponatremia is a no-no. Keeping sodium levels at a higher level of normal is something which we should do in these traumatic brain injury patients.
Yeah,
now,
and the beauty of using hypertonic saline is that you can give repeated doses as well. So you can start off with maybe 50 ml. Like I said, 1 to 2 ml per kilo. You can start off with 50 ml. This is very, very useful intraoperatively. This is what we have seen. You give just small doses, 50 ml, and see the effect. The effect is fairly immediate. And you see that there is a reduction. If not, in 10 minutes, you can repeat another dose. The beauty of hypertonic saline is its repeatability. Whereas with mannitol, it's difficult to keep repeating this frequently.
Okay. We find that many of our head injury patients have fever. And so how can hyperthermia occur in, how does it occur in traumatic brain injury, and how does it affect the brain? This question is for Malati.
Yeah, so hyperthermia per se, there are, especially if there is a pontine hemorrhage or brainstem injury, that can itself lead to thermal temperature dysregulation, and therefore hyperthermia can occur. Hyperthermia can also be because of an intense inflammatory response that the body has instituted in response to the head injury. Just like we have immunosuppression, there can again be hyperthermia which is instituted. But more important than all of this is you have to check whether there is any secondary infection, especially in the lungs. Pneumonia is the most common reason why patients are likely to have fever.
Yes, can you hear me? Coming to Karnik, ma'am. Now, hypothermia is obviously detrimental to the brain, and hypothermia has been used earlier. So can hypothermia be used, and is it therapeutic in any way?
Yeah, hyperthermia increases the cerebral metabolic rate of oxygen, and therefore it is absolutely we need to control. But whether the opposite, hypothermia or reducing the temperature, will protect the brain or no is the big question. When it should be instituted, how long it should be continued, and all those things are the controversial subjects. There are two aspects. One is the induced hypothermia, and where we are deliberately bringing down the patient's temperature. Now, this is usually happening when the patient has very severe head injury. Patient is having means being given some sort of therapy like barbiturate coma and all. But barbiturate coma will reduce the cerebral metabolic oxygen only during the activity. The cellular activities will be can come down on cellular requirement can come down only if there is a hypothermia. So that is why this hypothermia interest was there. There were multiple studies. Some gave for 24 hours. Early onset of hypothermia given for 24 hours. Then when that didn't work, some studies came with the positive results that when you gave it up to 48 to 72 hours, it is affecting somewhere in the favorable way. And that is why for in between few years, that was found to be beneficial along with the other regular management and all. The most recent guidelines are coming from the Polar trial. And Cooper et al. Did this study in 5,000 plus patients and all those things. And then what they have done is they have started hypothermia much earlier, even in the pre-hospital phase. So before the secondary injury takes place, if you can reduce the cerebral metabolic rate of oxygen, whether that can cause any cerebral protection, whether that can affect the outcome or no. But even the results of those trials have said that at 6 months, there is no change in the outcome, the mortality and overall it remains same. So it's beneficial effect, whether it really helps or no, is still in doubt. And there is no sure shot way that whether it can be considered as the therapeutic or no. There is still doubt. Apart from that, there is something called induced hypothermia, means passive hypothermia. Instead of actively cooling the patient, whether just not warming the patient intraoperatively, whether that can be used or no in a beneficial way. And some people have found that the passive hypothermia that can occur by not warming, that instead of 37 degrees centigrade, probably at 35 or 36 patient behaves better or no. It is general observation that it helps, but there are no randomized controlled trials and proofs or anything which definitely can point out that it is helpful and it should be used. So hypothermia is still a question mark.
Yeah, while it is a question mark, if a patient with traumatic brain injury or a multiple trauma comes to you and the patient has a lower temperature, don't try to warm the patient very rapidly, because that could be detrimental. And the second thing, as you say, that before the secondary injury occurs, if we could keep the patient at a lower temperature, it could help.
Maybe.
So this is, yeah. Thank you very much, ma'am. Now coming to Kondwilkar, ma'am. Ma'am, we are giving anti-epileptics to each and every patient of traumatic brain injury. And calcium channel blockers have also been, like nimodipine, have been found to be useful in these patients. So what is your take on this, ma'am?
Mission guidelines say that prophylactic use of anti-epileptic is of no use. So if you just say that the patient has an injury, no convergence evident, and just giving phenytoin is of no use. There has to be a definite evidence of at least subclinical seizures or convulsive activity. Then you can start this thing within first 7 days. The drug of choice, they still say it's phenytoin. They have compared that drug with the newer drug, Cerebral or something like that. But then there are no very encouraging reports, comparable reports of that drug. Although in our hospital, surgeons have been using that drug very constantly. Coming to calcium channel blocker, it has again a very specific role in cardiac hemorrhage or with the vasospasm. So unless there is a definite evidence of vasospasm, and also you can diagnose with the modalities like vasospasm, activity of clinical engagement. The common drugs which are being used, nimodipine, nifedipine, and many more other calcium channel blockers are being used. The dose of calcium channel blocker is about 60 milligrams. Or if you want to do it lesser, you can go 4 times to 30 milligrams. Role of calcium channel per se is not in general degree. There has to be evidence of vasospasm. That is why it is taken.
Basically, using anti-epileptics to up to 7 days may be an okay, but you should not go beyond that because you don't have any conclusive evidence on that. Calcium channel blockers, yes, it may help, but maybe you need to know whether there is some amount of vasospasm in the patient, and only then you move ahead on that.
Anti-epileptic, not prophylactic. Prophylactic randomly you can't give because it has no role to play. There are definite distinct that, or there might be a distinct, but that subclinical evidence you will have only when you do the EEG monitoring. This most of it is not possible.
It is almost a protocol in the hospitals to start the patient on anti-epileptics immediately as the patient comes in. But probably there is no evidence to the use of these anti-epileptics in these patients. Now, coming to Malati again, literature states that there is a use of certain drugs like amantadine, and even progesterone helps in traumatic brain injury, and so the incidence of complications in females is said to be less. Like secondary brain injury comes in later on because progesterone is said to help in traumatic brain injury. Any take on that, Malati?
I'm not so sure about progesterone, Pragnya. At least the papers that I have read have not shown progesterone to be useful. There are, of course, studies which say this way and that way, but
Yeah.
most of them are inconclusive, and I'm not really too sure about progesterone. But about amantadine, I have had the occasion to use it a couple of times, and certainly for a temporary period, for sure, amantrel is what we have available. Amantrel given orally through the Ryle's tube has helped in a patient who's recovering. Their functional outcomes become better only for the period which you use. And if you continue to use it for a longer period of time, it doesn't show any improved or better outcome than not using it. So for short periods of time, when for some reason you want to know, or you want to get to know what is the best response that this patient is capable of, certain times you need that. That is when amantadine helps. I'm not too sure about progesterone though. In fact, there have been some studies where even erythropoietin was used to see if using erythropoietin could carry enough, better oxygen, could give more oxygen to the tissues that needed them. And but even erythropoietin has not been proven to be useful. Does anybody else know about progesterone? I'm not too sure about that though.
Actually, literature says, again, as you said, there is no conclusive evidence on the use of either progesterone or erythropoietin. But there are studies where progesterone has been used, and in some cases, it has shown some benefit in terms of limitation in the secondary effects which occur due to traumatic brain injury. Yet nothing is conclusive.
Yeah, progesterone does have a cerebral protective effect, but I'm not too sure whether it influences the long-term outcome of the patient.
Yeah, no. Many of these drugs are under study, and the 6-month outcome which we talk about is not very great. Yeah.
But the only drug which is used as an adjunct and which is perhaps underutilized in head injury is tranexamic acid. It has a fantastic role to play, and it really changes. It's a game changer for many patients.
Could you throw some light on that, Malati, since you have talked about tranexamic acid?
Yeah, it limits the amount of, especially in cases of hemorrhage, like subdurals or extradurals, because it tends to cause a more sticky clot. It tends to sort of plug the rupture that is there in the vein, which has caused the bleeding, or the artery. Of course, if it's a major thing, nothing can happen there. But intraoperatively, it helps in achieving hemostasis quicker. And tranexamic acid limits the amount of hemorrhage that has occurred before the patient reaches the operation theater. So that has it has very good evidence, perhaps even level 1 evidence, that it has helped in neurologic outcome, better neurologic outcome.
Thank you, Malati. Now moving to the next question.
Can I add one word about that?
Sure, ma'am.
Yeah. About this early administration of tranexamic acid also has been positively found to be beneficial. In fact, now the CRASH 3 trial results have come out, and they have said that if it is given within first 3 hours of admission, or even before admission, within first 60 minutes of the injury, then the results are much beneficial. It is significantly reducing the size of the clot, and then that is recommended to be used. And early administration really makes the difference. The later ones, probably it may help, but early administration really helps. Up to 8 hours, the results are equivocal, but up to first 3 hours, it is definitely beneficial.
So it is for the ambulance team who actually reaches the spot. If such a situation should occur, then they can administer it on field. But if a patient has come to the hospital without having had a CT scan, then the CT scan should determine whether you are going to give tranexamic acid or not, because it's not going to be of any use in patients who have simple concussion. It's going to be useful when there is a breach in a vessel.
Yeah, a moderate to severe head injury rather than.
A little bit on neurogenic pulmonary edema and management, ma'am. Karnik, ma'am.
Initially, I did mention that brain injury affects all the systems and all, and neurogenic pulmonary edema is also one part of that. Trauma causes intense stress, and lot of sympathetic stimulation takes place, and probably as a result of that, the neurogenic pulmonary edema takes place. Quite often it takes place within 2 to 12 hours of severe, moderate to severe head injury, and up to 20% incidence in severe head injury has been noted by certain people, certain authors. Severe sympathetic outflow can probably lead to the pooling of the blood into the pulmonary circulation, which is relatively having lesser resistance. Even contributing factors are considered as severe sympathetic spasm or overflow can lead to myocardial ischemia, or it also increases the capillary permeability, and that is why this pulmonary edema develops. The clinical picture is the same as what we see in the other pulmonary edema, the frothy sputum and the hypoxia, usually associated with the hypertension and all. And as far as its management is concerned, it is usually symptomatic. Of course, it is happening because of the severely raised ICP. So the ICP correction is the mainstay of the management. Apart from that, we may have to give the positive pressure ventilation. If there is hypoxia, additional supplemental oxygenation, and appropriate ICU care. The PAP pressure monitoring and ICP monitoring does help over here. And other management that has been proven to be helpful is using nitric oxide. If the patient has already developed ARDS type of picture, then our management, ventilatory management and the other management will be typically same as the ARDS. So accordingly, that needs to be managed. Usually controlling ICP reverses or reduces the severity of it. That is what we have seen.
Thank you, ma'am.
Yeah, I would like to add just one small point here is the FiO2 that we give. You know, there was an occasion when somebody who visited our ICU had told us that don't give too high FiO2s in patients who have head injury and even if they have pulmonary edema. While that is true, you have to adjust the FiO2 to target your PaO2, especially when there is pulmonary edema of neurogenic origin or of whatever origin. Achieving good PaO2 is essential to achieve a good amount of oxygenation in the brain. So you adjust and titrate your FiO2, if necessary, even higher FiO2s to get adequate arterial oxygenation. That is important in this setting. It is just to add on, you know, some people may have some confusion about not using too high FiO2s, but that again, that has to be targeted for our effect.
Yes, Malati, you're absolutely right. Like from the outset itself, we have said, right from the part where you want to intubate the patient, what is most important is giving adequate oxygen to the brain. And then you do not have to worry about so many other factors which may come into play. Now, coming to the effect of anesthetic agents on the ICP, you have already told us, ma'am, in detail, but I would like to know which are the agents which you have been using and what is the role of newer agents like desflurane?
Okay. At the outset, I said I have not used desflurane much, but one thing is very sure that it causes hypertension, and I was sure that quality characteristic does add to the ICP. Coming to the classification of the anesthetic the other agents used, let's take the muscle relaxant with your subclinical, if you are using still, it does cause ICP, rise constantly and comes back. But it may be detrimental in the patient who are already have high ICP. So in such patient, it is better to avoid, but if it has to be used for some reason that we are anticipating you want to integrate, then we may access that by and large for some time. Muscle relaxants are not known to cause any rise in the ICP unless there is a hypoventilation. So it is not a muscle relaxant, it is a hypoventilation causing hyperthermia. Other drugs that I have been using that I have used was spectrum of drug with my 30 years of anesthesia, and then switch over to propofol, even had a study on midazolam and pandemic luxury trials. So amongst this, of course, propofol supposed to be a more favorable drug in terms of causing least amount of disturbances in terms of ICP. So, but if it is given for prolonged time, in fact, it's not a neuroprotective drug. Barbiturate, again, if first is given, it has the distinct effect. And of course, beyond these drugs, I have not used narcotic analgesics. We've been using fentanyl since long time. Before that, we have buprenorphine and Betadine. Of course, I have no experience of Betadine being used in anesthesia. And constantly either buprenorphine or this. So you have to really remember that this is of anesthetic agent at this hour when I'm hungry. So I remember at this point of time only 4 or 5 drugs. So the others too may add to this.
Ma'am, Karnik ma'am, Malati, could you add anything on what ma'am has already said?
Yeah, so I would like to just elaborate a little on the use of desflurane. I have used desflurane. It has been my favorite agent for maybe 15 years now. But in the head injury setting, let us say acute head injury who comes for a decompressive hemicraniotomy or a craniotomy, desflurane has no greater advantage. In fact, I would prefer not to use desflurane in that setting. Sevoflurane is certainly more stable and probably has better effects as far as the ICP and perfusion are concerned. But in a patient who has had a head injury, who has been ventilated, who is polytraumatic, who's recovering neurologically, and who is now coming for, let us say, long bone fracture fixation, or for some other reason that needs to be explored, desflurane works wonders if you want to have a patient who's breathing well and whose neurologic status you want to assess immediately after the surgery. Desflurane works well. Such people also tend to have fairly unstable hemodynamics, and you don't want to give too high a dose of anesthetic agent. They may already be on dexmedetomidine sedation. I tend to use a little bit of polypharmacy in this situation and tend to go lower down on the anesthetics. And then in such a situation, desflurane is wonderful to use, provided I'm using lesser than 1 MAC. Maybe I just use 4-5% of desflurane and combine it with small amount of dexmed or something as a supportive measure, and not give too high an anesthetic because I want the patient to be more responsive at the end of surgery. But this is different when this patient comes for, let us say, an extradural hematoma or a subdural hematoma or a decompressive craniotomy. Then sevoflurane, even isoflurane, works well enough because you've got the skull open after a particular point of time. Again, all this is depending on what dose you use. This thing is how much MAC you're using. If you're not too sure what MAC, you don't have anesthetic gas monitor, sevoflurane is the best agent to use. But if you happen to have AGM and if you happen to be in control of many other situations, then even using lower amounts of isoflurane or desflurane are okay.
Yeah, even I completely agree with Dr. Malati that our choice for the head injury is the sevoflurane that has the best cerebral dynamics. Desflurane has got slightly negative, but theoretical there is a minor difference. And we can use desflurane. However, our choice is sevoflurane, that is the best. Whenever we use either sevoflurane or desflurane, we ensure that we are using the drug in a lower concentration, usually restricting it to 1 MAC or lower. And that's what we are doing it commonly. If the patient happens to be obese and we want a recovery, desflurane scores as far as clear-headed recovery is concerned. So that is what advantage. But we use commonly Sevo.
Okay, coming back to Dr. Malati, your experience on use of intraventricular catheters, if any, and how are these newer, you can say, the newer techniques, because they are not really available to all of us? useful?
Yeah, so theoretically there are, invasive and non-invasive methods of monitoring ICP. There are indirect indicators of what the ICP like we've been discussing right from the beginning. And I have only used ventricular catheters. So EVD, this is the external ventricular drainage. And I think it has a great role to play when used in the right situations, because it also tends to be therapeutic, not just diagnostic. Not only does it tell you what the pressure inside the ventricle is like, but when the situation calls for it, you can even drain the CSF and reduce the ICP. So that has a double advantage of being a diagnostic as well as a therapeutic tool, as well as being very cost effective. But it again depends on what kind of ICU setting you have, what kind of theater setting you have, because in not all situations is it possible to put the EVD. Placing the ventricular catheter itself needs to have some adequate size of ventricle available. In a completely compressed brain, it's not possible to even introduce the ventricular catheter, and it has a potential to cause, hemorrhage or bleeding from the site of entry. And infection, of course, is a very major thing, and ventriculitis can be very morbid for the patient and even contribute to mortality. So using EVD has to be done if you're comfortable with it, and if your theater setting and your ICU setting allows for it to continue to be used in a sterile fashion. Pragya?
Now, since the beginning of this webinar, or this panel discussion for that matter, we have been saying that the oxygenation going to the brain is the most important. So, Karnik ma'am, could you throw some light on the role of cerebral oximetry and jugular venous oxygen saturation measurements, though we may not be using that?
Actually, we have used both at different time frames, time places, and all those things. Jugular venous oximetry is not a new technique, and that has been going on since many years and all. Usually it tells us that how much oxygen is left after the blood has left the brain. And in 2002-03, we were putting lot of jugular venous catheters for collection of this to see whether we can do something, and it can help us in guiding the oxygen therapy or ventilation or the improving the cerebral perfusion or so. But then the literature as well as practical experience and all was not actually helping us in guiding our therapy. So that remained as an experimental utility only. It gives us the global oxygen saturation, venous oxygen saturation. So overall global status of the brain, we come to know. As against that, the cerebral oximetry, that is NIRS based non-invasive technique, gives us the amount of oxygen that is there in the brain underneath the sensor, wherever the sensors are placed. Commonest site is the forehead, and whatever amount of oxygen is there in that region is picked up. Of course, the proper calculations and whatever is there in the skull and the subcutaneous tissue and all is subtracted and all those things. But predominantly that also gives us the venous oxygen, predominantly the venous saturation is being told. Now, when we are talking about head injury patient or traumatic brain injury, the area that we are interested in is the penumbra area, and that is not being picked up. So whether really we can assume that a cerebral oximetry is good, so everything is hell and hearty, is not really true. What we need to measure is the oxygen going into the at-risk brain tissue needs to be monitored. So there, both these techniques become inadequate. Ideally, we should be using the invasive technique, that is the brain tissue oxygen oximetry, PBT-O2 should be measured. But then that is rarely used, and I don't think any of the centers are currently using it, and whether they are finding it useful or no. None of these techniques are newer techniques. They are all more than 15, 20 years old. So whether they are really useful or no, that is doubtful. The cerebral oximetry, even though it sounds popular because it is non-invasive, has not really been helpful in guiding the therapy. Having said that, both cerebral oximetry as well as jugular venous oxygen saturation is reasonably reliable indicator of brain death, or it can be used for a prognostication. So jugular venous oxygen saturation, if it is say above 85%, that means brain has not used any oxygen. That means the brain metabolism is nearly gone. Patient is brain dead. That sort of outcome assessment has been done. Cerebral oximetry is relatively better. Even it is useful to see the adequacy of the blood supply. So whenever there is a global ischemia type of situation, at that time it is more useful rather than the traumatic brain injury. Say for after cardiac surgery or the carotid artery surgery, where the blood supply is going to get significantly altered and all, where the cerebral oximetry can give us some idea whether the blood supply is coming properly or not. However, there is a grossly limitation in traumatic brain injury.
I agree, madam, that focal oxygenation or focal hypoxia is not something that you're able to pick up with this. It's more of a global cerebral indicator. And have you had the occasion to use transcranial Doppler in any situation? That seems to be quite promising and probably least invasive. And now that ultrasound is coming in a big way in anesthesia and in critical care, perhaps TCD can have a better, use.
TCD is really useful in traumatic brain injury. Also, there are promising results and all. We do have TCD, but currently it is not working, and not working since a long time. So I have not had much chance of using it. I have seen it being used in other ICUs and all, and it is definitely sounding promising. Not only TCD, we can have a combination of 2 or 3 things. In fact, so much so that that has actually reduced the need for the ICP monitoring. So now, rather than ICP monitoring, we are more likely to use this multiple other monitors, which tell us more about the CPP rather than the ICP monitor. Otherwise, for ICP, we have used the intraventricular catheter, we have used subdural bolts and all, but all those things a long time ago. Now we have the Codman catheter, and even the Codman has come out with other catheter that instead of the brain tissue, inserting it into the brain tissue, they can insert it into the ventricle, so that you can use it only for, not only for ICP monitoring, you can also aspirate the CSF from that. So it can be used in a therapeutic way. But the cost is tremendous. The Codman catheter with this double thing is, I think, 40,000 per catheter or something. So I think that is something impractical for our population. So that's there.
Thank you so much, ma'am, for your from what you have told us regarding these oxygen monitoring equipment which is used in traumatic brain injury or in neurosurgery, both, because many of us have not actually used any of these. Now coming to the question to Dr. Kondwilkar ma'am regarding post-operative extubation of this patient. When do you start weaning these patients, and how important is post-operative analgesia in these patients?
Now, weaning of this patient, I'm extubating. It depends that what was his status preoperatively, what was his status after the veterinary surgery was done, and what are the other diagnostic tools you telling me about this injury that the patient had. Now, patient of diffuse external injury may take very long time to improve. He may not improve also. But there are definite instances and definitely also patients are improving over a period of time. So such patient may require distinct post-operative medication for a very long time. And the extubation criteria for this, what is there? you have to switch off all your muscle relaxant. So, and keep them under the same sedation. But whenever you want, you can reduce the level of sedation instead of your distance. One. So, conventionally, when we see intubate or wean of our patient, we stop this muscle relaxation. We put them on a short breathing. We give them trial with the other modes of ventilation, like SIV or any other modes like that. In similar strategy, in our ICU, we used to use Cerebral because that can be switched off and switched on easily. This will provide anesthesia solution. The patient can accept this thing very easily. You will be able to check your neurological outcome and symptoms in this patient. So the benefit of this weaning can be given only to a patient if they are neurologically improving, and giving them trial of this intubation if they are maintaining their respiratory parameters. Because some patients may be having compromised neurological outcome. They may be in a vegetative state, and they may be able to maintain their respiratory and serious well. So, three criteria in such patients that they are not neurologically improved completely. That's one thing. That checklist we have to take from your surgeon, and there has to be a joint decision whether to extubate this patient now or when at what time. So that is one thing, neurological improvement. Whether the patient has been maintaining the last 48 hours is cardiovascular stability, and what is the respiratory drive. Then get on a different mode of calculation, I will calculate that. One of the legal criteria is considered. Now, I will intubate into the patient. You have to be always in a readiness to intubate that patient. Again, if anything goes wrong. So therefore, it's a very wrong process that over a period of time, you may take 24 hours to make that decision complete, whether to intubate or not. That's the only way you patient and a different mode of ventilation. As far as the post-operative anesthesia is concerned, post-operative anesthesia post-operative is required. But in head injury patient per se, they may not require the anesthesia for their neurological disinfecting. They may have a pain because of their craniotomy issues on the craniotomy side may give the anesthesia. But if you have used in acute setting, the scan block or even within the scan block later on at the end of the surgery, that can work for some time. You cannot keep on repeating that scan block for number of times. So we have switched over but for ventilation as well as anesthesia, expiratory works wonder. They don't need any additional. But all they require is they are completely or if there are any vital changes because of the pain, then supported by paracetamol. We have definitely been avoided research on other narcotic analysis because that may hamper your assessment of neurological function, or they may again hamper your cardiovascular stability, bradycardia, hypertension, so the best combination for ventilation, sedation, and anesthesia, we have always used either respiratory. Earlier we used to use sort of propofol again as over a long time and disadvantage of Now recently regarding the long-term ventilation in these patients, that if you have to ventilate this patient for a long time, earlier they said avoid the patient, but recently the guidelines I have they said for a long time. It is better to have the planned first time on these patients because it is easier to see rather than giving another common infection by keeping the two for longer time. There are chances that this patient will block this infection in this patient. So once a tracheostomy is given to the patient in the planned fashion, the healing becomes more easy. You can evaluate your patient's respiration and other parameters very easily, and you can reinstitute this ventilation to the tracheostomy. So I think that's all about this question.
Thank you, ma'am. Ma'am, Malati ma'am or Karnik ma'am, do you want to add to this regarding post-operative analgesia especially?
Oh, I think she has covered almost everything.
I agree with what she said.
Yeah.
It is impractical to repeat blocks. Analgesia, generally, actually, these patients do not need too much analgesia if there is just head injury or for just a craniotomy. If there is polytrauma, then we have to think of other, maybe blocks or something that can be used on a continual basis or as an infusion basis. But other than that, in my experience, it's not very necessary. If you know that this patient is likely to be ventilated or, on a tube for a long period of time, then even using fentanyl patches is not a no-no, provided you have a fairly lucid patient. So these again are situations, these are gray zones, when to use what. Dexmed is an absolutely wonderful drug that has been introduced for us, and it is a lifesaver in many situations. A very small dose of dexmedetomidine has been useful. You don't need to use higher doses. If higher doses are needed for sedation, then you might need to consider using a vasopressor if you are going to use dexmed as a sedative, but not as an analgesic agent. And dexmed tends to have effect even for a much longer period of time after stopping the infusion than we think it to be, though, because probably of cumulative effect that is there. As far as weaning and extubation is concerned, what Madam said was true. If you happen to catch the patient in a lucid phase, then you can think of extubating on table. But otherwise, the question of shutting off paralytic agents, seeing his recovery, this doesn't arise. Because once the patient goes to the ICU, very rarely we use neuromuscular or paralyzing agents to keep the patient ventilated. We tend to use other agents, and you need to wean them off the sedative agents rather than the paralyzing agents. That's all that I wanted to say.
This has been a very long discussion of 2 hours on traumatic brain injury. I have a few more questions, but I think I would not like to ask them now. It has really put all my residents, doctors, and even the private practitioners, those who are working in the various institutions, as also who may not be working in neuroanesthesia on a daily basis, they have definitely benefited because of this particular discussion which we had with these stalwarts in neuroanesthesia, Dr. Kondwilkar ma'am, Dr. Hemangi Karnik ma'am, and Dr. Malati Panchawagh. Thank you so much for being here for us. I would like to extend my thanks to all of you and would like to felicitate all of you. Now, this particular felicitation is for Dr. Malati Panchawagh, who was not there earlier with us in the morning session. And as we all know, for those who have joined in late, Dr. Kondwilkar ma'am has received the A.M.Deshpande Oration Award for this year. This is the 6th time which we are giving the award. And this is generally given during the ProAct PuneCon, which we have, which is actually a huge conference which we have. It's a 2-day conference which we hold in a physical manner, but because of the COVID situation, we were not able to do it this time. And so we could not call you and actually give you the various, the hospitality of Pune, which we could have otherwise extended to all of you. We could not do that. Thank you very much, all of you all. And over to Sushma ma'am.
Society of Anesthesiologists Pune would like to take this opportunity to inaugurate our first e-bulletin. The theme being for this bulletin is obstetric anesthesia. This e-bulletin contains 3 articles. The first article is an experience shared by a smart group on a labor analgesia. The second article is a write-up by Dr. Neha Kulkarni. She narrates her experience on a successful management of a parturian presented for C-section with undiagnosed cardiomyopathy. And the third article is the Marathi poem by Dr. Kirti Kundalwal named Prasuti Kala Banlya Chaitanya Layari, which depicts the experience of a would-be mother going through a labor pain and the feeling of a mother of a just born baby. So I would like to conclude the session by giving a vote of thanks. So I thank our faculty, Dr. Kondwilkar Madam, Dr. Hemangi Karnik Madam, and Dr. Malati Panchawagh Madam for their such a elaborate, extensive presentation on a very relevant topic. And this has definitely enriched our knowledge on a traumatic brain injury. I would also like to thank all the delegates who have joined with us for this webinar on a Sunday afternoon. And I would also like to extend my vote of thanks to Dr. Ashok, Shyam and Rahul Choube for giving us a huge platform for presenting this webinar. So thank you all once again and have a good day.